Okay. We're not live?
No, we are live. I just need your assistance.
All right. Oh, we have people. Okay. Good morning. Good morning. All right. Yeah. I'm talking to an empty room. Okay. So over the weekend, you guys had two chapters, chapters 5 and 6. 5 was on dementia. 6 is on skills, which we're going over in class. So let me go ahead and get your scores for what you did. Kaylee, Annalise, Nicole, David.
I got 100 for chapter 5 and a 90 for chapter 6.
Thank you. Renesha, Michaela, Jacob, Oriana, Julie.
195.
Thank you. Elizabeth.
I got a 90 on the first one and didn't get the chance to do the second one.
Okay. Russell,
100.
Finley, Gabriella, Isabella.
I got a 95 on both.
Thank you. And Medina. Okay. All right, class is half over. Have you registered for the test yet? If you have not, this is a good time to do it. The class and the test are not tied together. There's no time period where you have to register within so many days of completing. It doesn't work like that because you guys are challenging. So the class and the test not tied together. You can take the test whenever. But I will tell you that the longer you wait, the less confident you're going to be. And that's just a fact of life. When you're in class, you're not very confident because you're watching me do the skills and you're comparing yourself to my performance, and that's not fair. Remember, I've got 30 something years on you. Okay. So that's not fair. Don't compare you to me. Compare you to other yous. Right? Everybody's going to be kind of fumbling through the test. It's not going to be all pretty. There's going to be, oh, I got to do this, and that's perfectly okay. That they're not grading you on how pretty it is. They're grading you on the checkpoints. That's it. Just the checkpoints. So learn the mechanics of doing the skill. Pretty comes later. But the problem is that if you don't take the test, when you get out of class, you're thinking to yourself, yeah, I'll practice and then I'll register. Once I get more confident, more comfortable. Life is going to get in the way. It always does. And 6 months goes by and now you're not confident at all because you can't remember half of the stuff that I said. And then a year goes by and, oh no, now you need to work as a CNA because the economy isn't doing so great and it's the only thing hiring and I got to start all over again. It's this cycle happens. So my suggestion to you, register for the test. Take the test. You're probably going to do way better than you expect to. Okay. It's my little pep talk for today. All right. Game show is coming up the first Tuesday in November. You guys actually will be graduating before that. Okay. So the next game show will be after your graduation. Just kind of keep it in mind. It will be a good review for you before you get ready for testing. Good? All right. So I'm going to go through this review very, very quickly. Next class is our very last review. After next class, there's no more review. So this is not the last time you'll see this, but close to it. So how do we know what to do with each patient? We follow the care plan. The care plan, the whole care plan, and nothing but the care plan. And while we're doing that, we should be making observations. Anything that we notice, we report to the nurse. So I want to stop here and talk about some current events. This just happened this weekend. Heartbreaking. There was a dementia patient who was, I believe, now I might get the ages a little, wrong because I don't have anything to refer to, right? But 95 years old, dementia patient, 95 years old. Good morning. She got a new roommate, 89-year-old roommate. Okay. So they're in a locked dementia unit at a facility. This 95-year-old beat this 89-year-old to death with a leg rest of a wheelchair. Beat her to death. Now that's absolutely tragic, horrible. I can't even fathom. This 89-year-old victim was a Holocaust survivor. And she is in an institution designed to keep her safe, and she ends up being beat to death. I mean, you can't write that kind of tragedy. That is absolutely horrible. Now, this is even worse. This makes that whole situation worse because I painted a picture, 95-year-old dementia patient. You're thinking she has no idea what she did. She went outside and hid the weapon, the wheelchair leg rests. She came back inside and nobody understands how she snuck out and back in. They haven't figured that part out yet. And she was found washing the blood and cleaning the scene. Did she understand right from wrong? Well, it kind of looks that way if she's hiding evidence and trying to cover the scene up. We don't know. We have no idea what her mindset is. Now, this is a very tragic situation for all involved. She was arrested. She is currently in jail at 95 years old, awaiting trial. She will be tried for this crime. Now, there's going to be a lot of lawyers involved. There's going to be a lot of psychologists involved. There's going to be a lot of discovery and all of that. It's a horrible situation. My heart breaks for both parties involved in that situation. And here's why. If your family member has dementia and you do not feel that you can keep them safe at home, what do you do with them? If your mom all of a sudden developed dementia and you were afraid she would wander out and get hit by a car, what would you do? What would you do? What's that? Put her in a care home because you need somebody that can be awake and alert 24 hours a day to see to her safety. That is why patients with dementia go to a facility.
All right.
You do. All right. So safety is the reason we're there. Keep that in mind, right? So if we have,
We're good.
thank you. If we have a dementia patient in a facility, that is a strange place for them. They're probably going to be a little anxious, right? We talked about this on day one, getting into the mindset of your patients. This is a strange place. You're surrounded by strangers. You probably don't understand what's happening. Everything is new, and it's usually going to prompt some sort of a acting out situation because it's a new environment. Any change that happens in that environment requires coping. Coping skills are affected with dementia. That's why we have them in a facility. So we've got a dementia patient who has a safety problem in a facility and is going to be triggered by change. Now put a new roommate in that room. Is that a change? So when you have a new roommate put into a room, that requires that we do much more frequent monitoring, that we make sure everything is good, that we're checking, we're listening, we're watching for anything that we see. And anything we see, who do we report it to? The nurse. So I don't think, and I may be wrong, I don't know the situation, but I seriously doubt that these two women were getting along famously before the 95-year-old decided to kill the 89-year-old. There were probably signs. And that means either the staff didn't pick up on the signs or didn't do anything about the signs. And this is the tragedy that we are left with. This right here would have kept that 89-year-old alive. Do you guys understand how important it is that you report everything? I don't care how minor it is to you, because it might just save a life. Now, on top of that, you mean to tell me that this 89-year-old got a leg rest off a wheelchair, which is metal, beat another person to death with it, and nobody heard a thing? Not a thing? They didn't come in while she was beating the resident. She had time to kill that woman, go outside of a locked unit, dispose of the evidence, and come back in the locked unit and clean up before anybody recognized that something was wrong. Really? Because I watch movies and I have a surround sound system. And anytime there's a beating, I actually have to turn the volume down. You really think nobody heard anything? Observations. That's why we're there. That is the whole reason we're there. So now, because the staff didn't do their job, we've got a woman that's dead and another one on trial because we failed. I seriously doubt this woman was a 95-year-old homicidal maniac. She was put in a place to keep her safe. We failed. Do I expect that there's going to be some legal repercussions of this? Yeah, I do. And there should be. There should be. Staff should be held accountable for this. Administration should be held accountable for this. This is unimaginable. And my heart goes out to everybody involved because it was preventable. This was preventable. Do you guys understand the importance of this? Do you understand the importance of what we do? It's life and death. This is awful.
Every skill that we do is going to start with the opening. Every opening starts with a knock. And then we're going to greet the resident, address them by name, introduce ourselves by name and title, and tell them why we're there. So knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to whatever. Is that okay? Once we have permission, then we'll close the privacy curtain and go wash our hands. Remember that privacy curtain is not clean. You okay?
Sorry.
No, you're fine. Remember that you have to wash your hands before you get your supplies. One of the supplies that we have to, our cardinal rule here is don't touch resident until your hands are clean. That's our cardinal rule. One of the supplies we have to consider is gloves. We consider gloves for every skill on every patient because we're not sure when we're going to need them. If your patient has body fluids that you might contact, if your patient has personal skin that you might contact, or non-intact skin that you might contact, you need gloves. So I'll give you a good example of this. I'm sitting here holding a paper towel on me. I have a hangnail here that got snagged, and it's been bleeding now for an hour. Can't really get it to stop bleeding. So if I'm going to do a skill on somebody today, I have an open wound. What would I need to wear?
Gloves.
Gloves. So this doesn't just apply to your patient, it applies to you too, because remember that wound is a portal of exit and a portal of entry. You guys remember that infection control process, right? So if I'm going to do any skill on a live patient today, I need a set of gloves because I don't want them to contact my body fluids. Make sense? First thing your gloves should touch is the patient. Keep your gloves clean. That means we do all of our prep work first. Put the toothpaste on the toothbrush. Put the towel on the chest before you put your gloves on. Do all your prep work first. And then once you've touched the patient, you have to be careful about what else you're touching in the environment. You're going to remove your gloves correctly by pinching up at the cuff, taking off, and then going under to take the second one off. If we're going to use supplies, we need a barrier to put them on. Now, I had a question that came through my email this weekend that I answered. I actually answered like 6 questions for this one individual that had contacted me. This was one of the questions that, morning.
I'm so sorry. There's a gold Hyundai Sonata in front of our trailer that we would need to remove so we can hook it up.
Anybody in here have a gold Hyundai Sonata? No, nope, not it. You might want to try next door.
Next door?
Yeah.
Thank you.
You're welcome. Okay, so this was a question that I had. She went to a class, I believe it was in Ocala or Gainesville, somewhere up north of us. And they did not have barriers. They did not use barriers, didn't teach about barriers, and they didn't teach about privacy blankets. And she was wondering, are there, are you going to have those in the test? Do I have to use them? What are the rules around these two things, barriers and privacy blankets? And barriers, there are some skills that they don't directly require a barrier. There's no checkpoint that says use barrier. But there are checkpoints that you have to use a barrier to complete, like for any bathing skill, don't put soiled washcloths directly on the overbed table. So if you have a barrier there, it's keeping the soiled washcloths from contacting the table. Don't let the foot touch the bare floor. Well, a barrier would accomplish that. So even though it may not be a direct checkpoint, use barrier during this skill. There are some checkpoints that will be checked off because you used a barrier indirectly. Make sense? So what we want to do is just provide a clean place for our cleaning supplies. That's the whole purpose of the barrier. You only want to touch supplies with your clean hands. Don't let the supplies touch your uniform, and get the barrier first before you go get anything else. I also, when I answered that question for the individual, I also sent her a screenshot of On Prometric's website, if you go down, you see testing center resources. There's actually in there, it has a list of supplies that all the testing centers have to have on hand. And barriers and privacy blankets are both listed. So these are things that they are going to have at the testing center for you to use with the expectation that you will be using them. Okay. Unfortunately, there's a lot of places that teach that aren't test specific. You know, that they don't really give you testing information.
So it says documentation. So during the test, will we put a barrier down?
Okay, so a documentation clipboard actually will be handed to you at the beginning of any documentation skill. It's a clipboard with the documentation form on it. But,
We're gonna have to figure something out for StreamYard. Can you turn your device off and then back on for me, please?
Unplug. Or get out, yeah, take StreamYard down on the Mac.
Let me try one more time here. I'm gonna try something else. See if I can just get the microphone to reboot.
Yeah, I'm on. Yeah, it was off of that one.
Still not giving me the
I
option.
have to take.
Yep. On it. Don't understand why it's not permitting you to use.
That should work now. All right. Testing, 1, 2, 3. Testing. Testing. Okay. Uh-oh. So much tech. 2 computers, a monitor, sound. All right. Let's try again. Privacy blanket. This is used anytime your patient is uncovered. No? Oh. Okay. Give me a second, guys. I think we're ready here. Yep, technical difficulties. Okay. So privacy blanket is used anytime your patient is uncovered or undressed. Remember that you perceive temperature differently than your patient does. You're going to put the blanket on, not snapping it or shaking it, and pull the sheet down underneath, and you'll remove after you take your gloves off. Linen rules. If we're going to use any linens like washcloths or sheets or towels or pillows or anything, you don't want to hold them up next to your uniform. You have to have clean hands to get your linens. Don't snap or shake them. We know all of those rules already. Clean rolls toward you, dirty rolls away. Don't let anything touch the floor, and use it or lose it. Scoot and roll. You're not going to have side rails in all settings. Side rails do not keep your patient safe. They actually provide an obstacle and can make injury much more severe. So you don't need side rails to keep your patient safe. Just keep them in the middle of the bed. That's it. Keep them in the middle of the bed. But if you have to turn them over, they need to be in the middle of the bed after the turn. So that means you're going to scoot them towards you first and then turn them so they're in the middle of the bed after the turn. And you always turn a patient facing away from you. Anything that we wash, we have some rules for. Don't add soap to the basin. Whatever you wash, you rinse. Whatever you rinse, you dry. Don't get your surface wet. When you're getting water, use a paper towel to turn the faucet on. Check it with the inside of your wrist. It should feel warm, not hot, not cold, just warm. And ask your patient to check it as well. If the water gets cold or soapy while you're cleaning, change it. Don't ignore it. Change it. And if you're going to put lotion on, warm it up first and then wipe off the excess. Guys, if you notice, every single one of those checkpoints has something to do with the patient, not you. Don't use cold water on the patient. That's icky. Don't use soapy water on the patient and not rinse it off. That dries the skin. Everything here is all patient focused. And that's what they're going to be grading you on. On the test, that evaluator's sole focus is the patient, not you. You think they're grading you. You think the focus is on you because you're being tested. The focus is not on you. They are not grading you. It's important that you understand that. They are not grading you. They are grading the actions you do and the effect of those actions on the patient. Has nothing to do with you. Has everything to do with the patient. And if you understand that, if you can kind of absorb that, testing becomes much easier, because if you're focusing on the patient and the evaluator's focusing on the patient and everybody's focusing on the patient, you're going to pass. It's when you start focusing on you. Like if you're told to take a radial pulse and you pull out your stethoscope and listen to the heart, that's all about you. You're showing how fancy you can be. You're trying to impress the evaluators. Are they going to be impressed that you didn't follow the care plan? No, it's not about you. It's about the patient, what's best for the patient. Okay, if we use a basin of any sort, we're going to have to clean that basin. Cleaning a basin, super easy. Dump it, rinse it, dry it, store it. It's that simple. They don't care how you accomplish it. Dump it, rinse it, dry it, store it. If it's body fluids, like elimination fluids, put them in the toilet. That's it. That's all you need to know about basin cleaning. You can get really, really complex. You can get in the weeds on this. Test isn't in the weeds. Rinse it, dry it, store it. That's it. And then every skill ends the same way with the closing. Lots of C's here. You're going to make sure the patient's in a clean and safe environment. They're covered. Make sure the bed's in low position. Give them their call light. Ask if they're comfortable. Address their preferences. That's all part of comfort. Open the curtain and clean your hands. If you have to chart, clean your hands again. A lot of C's there. Okay. We learned how to take a pulse. A pulse is a measurement of how many times a heart beat over 1 full minute. You don't always have to count for a minute. We're going to count as long as care plan tells us to. but we're going, the number is always over 1 full minute. So if you counted for 15 seconds, we got to make that into a minute reading. So we would multiply that by 4. Normal is between 60 and 100. Don't use your thumb to take a pulse. Use 2 fingers. Put your thumb on the back side to hold consistent pressure. You're going to count the number of thumps that you feel under your finger, and you're going to report that by documenting at the end. Normal is between 60 and 100. Dressing a resident. Remember, USA first. Undress strong arm first, and then dress the weak arm first. This means that your patient doesn't have to move that weak arm very much at all. Makes it super easy. Make sure you get the clothing before you undress the patient. Don't leave them there naked in the bed. That's uncomfortable. Even if they're covered by a blanket, it's still uncomfortable to be naked in front of a stranger. Right? Kind of icky. So make sure you're protecting their privacy. Doesn't matter how you dress them. Socks first, pants first, shirt first. Nobody cares. However you want to do it, nobody cares. What does matter is that undress strong arm first, dress weak arm first when we get to the shirt. If you want to do the shirt first so you don't forget, that's fine. If you want to start at the bottom with socks and move your way up, that's fine. That's the way I do it. And the reason that I do it that way is all about time management. When you start working, you're going to have way too much to do and not enough time to do it. That's just a fact of working in healthcare. It's actually a fact of working in most industries now. They're trying to squeeze every last second out of us. But in healthcare, it becomes even more important. Because remember, the main reason we're there is safety, right? We're trying to keep our patients safe. So the way you dress somebody can actually affect time management. If you start at the top, putting a shirt on somebody is much easier when they're sitting up. Makes sense, right? You're usually upright when, have you ever tried to put a shirt on when you're laying down? It is really, really hard to do. Try it. Takes forever. You have to wiggle back and forth. I mean, it just takes, so in order to put the shirt on, you're going to put the head of the bed up and put their shirt on. But now you got to get their pants on. Have you ever tried to put pants on when you're sitting on your butt? That's really hard to do. A lot of wiggling back and forth. So it takes a lot of time. So you really need the head of the bed down to put pants on. Putting the head of the bed up and down takes time, about 10 seconds each. So if you start at the top, you put the head of the bed up, you put the shirt on, and then you have to put the head of the bed back down to put their pants and socks on. That's extra time. And it doesn't sound like a lot of time. But if you do that for 10 patients, that can add up. Little bits of time repeated on multiple patients adds up. And this is why a lot of CNAs don't get a lunch break. Because if you just spend 2 extra minutes per shift with each one of your patients, just 2 extra minutes per shift, spread out over 12 hours, 2 minutes spread out over 12 hours. That's 10 seconds here, 15 seconds there, 30 seconds there, 2 extra minutes spread out over 12 hours. You've lost your break. So we have to be aware of time management. Little bits of time add up. So you want to be as efficient as possible as you're doing these skills. That's why I do the socks, the pants, head of the bed up, shirt. Most people, once they're dressed, don't want to lay back down and go to sleep. If they were going to stay in bed and lay back down, we'd leave them in a hospital gown, not fully dressed. Fully dressed means they're either receiving visitors or they're getting out of bed. Either way, they probably want to stay sitting up. Make sense? Okay. Oh, that deserves applause, apparently. All right. Make sure you put all the dirty stuff in the hamper when you're done and the call light goes in the stronger hand. Hand and nail care. This is a mini mani. Soak the hand, take it out, put it on a towel to wash. Put it back in the basin to rinse, put it back on the towel to dry. Clean under the nails with an orange stick, the flat end of the orange stick. File the nails in one direction and then put lotion on. Before you put the lotion on, warm it up. After you put it on, wipe it off. Clean your environment. Super easy. It's a mini-mani. But the whole reason you're doing this is to keep the nails at a natural length. If you file them once a week, you never have to trim them. Never have to trim them. Making an occupied bed. The whole focus here is to change that bottom sheet without your patient getting out of bed and making sure they're not on a bare mattress. So clean rolls toward me, dirty rolls away to change an occupied bed. Once you've got that bottom sheet changed out, corners all secured and no wrinkles under the patient, put a top sheet under them, tuck the top sheet under the mattress so that it's not just loose, and change the pillowcase. That's the whole skill. Super easy. Believe it or not, making an occupied bed, I used to do a whole lot more with my little kids when my children were little than I did in a clinical setting. Because when your kids are sick and they're laying in bed and the sheets are sweaty because their fever broke or they had an accident because they're little, getting them out of bed can be a little bit difficult. You might not want to wake them up. So this skill I learned and used on my kids more than I used in a clinical setting. In a clinical setting, anytime I walk by a bed that's unoccupied, I change the sheets. I mean, that's just routine. If the bed doesn't have a patient in it, the sheets probably need to be changed. Question I get asked a lot, though, is how often do we change the sheets? Well, how often do they need to be changed? That's really a very individual thing. If you've got a patient who's bedbound in that bed 24 hours a day, at least every 2 days. If you've got a patient that's in and out of bed, well, how often do you change your sheets? Probably once a week. If you've got a patient who has night sweats, those sheets might need to be changed every day. Would you want to sleep on sweaty sheets? So there is no one size fits all answer here. If in doubt and you got a second and the bed is empty, change the sheets. Everybody loves the feeling of getting into bed with nice, fresh, crisp, clean sheets. Makes you feel good. So if you can give that little bit to your patient, help them feel good when nothing else in their life is, that's a good thing, right? But it's way quicker to change a non-occupied bed than an occupied one. Side lying position, you're going to turn them on their side, use some pillows to keep them there. In order to turn somebody on their side, we scoot them toward us first and then position them properly for the turn. Furthest arm up, closest arm over, closest knee bent, furthest knee angled. Turn them on their side. Put a pillow behind their back to keep them from rolling. Put one between their legs so their bony areas don't touch, and put one under that top arm. Call light goes in the bottom hand. Foot care, just like hand and nail care, a little lower. Put the foot in the basin to soak, take it out to wash, put it in to rinse, take it out to dry. Look at the foot. That's the whole reason you're there. Warm some lotion up, put it on, wipe off the excess, put their sock and shoe back on. That's foot care. We don't do anything with toenails other than look at them and report our observations. Mouth care. You guys all know how to do this. Just make sure your patient is sitting up. Cover their clothing with a towel because they're going to make a mess. There's no two ways about this. Wet your toothbrush, put a little bit of toothpaste on and brush whatever they got. Top, bottom, front, back, tongue. Let them rinse, spit, and dry. Don't forget the dry. Clean your basin, put it away, clean your patient up. End your skill. This is a really easy skill. You guys are all familiar with this one. It's just a little high on the ick factor, right? We don't like to brush somebody else's teeth. I get it. Respirations is breathing. We're going to count how often your patient breathes over a minute. If you're only counting for 15 seconds, multiply that by 4 to get your minute reading. 12 to 20 is normal. Don't tell your patient you're counting their breathing. It changes their breathing. Okay, 12 to 20 is normal. Yeah. Oh, thanks. Sheila, hey, I took your class in June 2025 and passed both written and skills on my first try. Thank you so much. Your class was really helpful. Congratulations, Sheila. Great job. Great job. Congratulations. Okay. All right. In and out is counted as one full cycle. Remember, you have to document on this one. And range of motion, we have not gotten to yet until now. So there's 3 range of motion skills. I have not showed you any of them. We've had to skip 2 because of time. So I'm going to talk to you about this one, range of motion, hip, knee, and ankle. And then next class, we're going to add in shoulder. In the final class, final skills class next Monday, we're going to talk about elbow and wrist. So I'm going to bring the 2 in that we've skipped next class and the class after. But this is going to give us kind of a basis, a foundation to work off of. Range of motions are the easiest skills on the state exam, hands down, easiest. They're the fastest skills. In fact, if you look at the bottom of this page, you can see that somebody with your level of experience should be able to do this skill in 4 minutes or less. That is the quickest skill that we have. And all 3 range of motions are that quick. The video, I think, takes me 2 minutes to do. So super quick skills. This is all about the care plan, guys. 100%. This skill, what they're grading you on, is the care plan. You have to exercise the correct extremity with the correct exercises for the correct amount of repetitions. Put an opening in front and a closing in the back. And those are all of the checkpoints. Okay. Does that make sense? Now, along the way, we've learned a few things as well. Things like if you lift an extremity, you support it. You lift from below. Anything we move slowly, smoothly, no jerky. So I don't want to grab something like this and try to move it, right? We're not a crane, not the claw machine at Walmart, right? We always lift from below. And if you remember that, and we've learned that during sideline position for making an occupied bed, when we put the pillows in place, we've heard these things before. We're just going to apply them to this skill. So there's not much to learn here. Of course, we have to evaluate if we need gloves, because that's a per patient thing, not a per skill thing. So we're going to follow our care plan. We're going to do our opening. We'll figure out if we need gloves. We're going to do the skill and then the closing. So not much here. Not much here. So Pumpkin says, can someone tell Ms. Jones hi? Tell her I watch her videos all the time. Aw, thank you, Pumpkin. That's sweet. She says hi back. All right. So if you look at the top of page 81, you can see the care plan. We're going to read it together. It says, provide the following range of motion exercise to a resident's right hip, knee, and ankle. Flexion extension. Provide 3 repetitions of each exercise, and the resident's not able to help with the exercises. So flexion extension is an up-down motion. So if I ask you to extend your left arm above your head like you're asking a question, it's going to look like this. This is all of you could do this, right? Can you go ahead, extend your left arm above your head? Yeah. Hold it up there. Make sure your elbow's nice and straight. Bring it all the way down in front of you, not to the side, in front. Let's do that again. All the way up in front and all the way back down. Good. All right. That was active range of motion. I told you what to do. I critiqued you, made sure you were doing it right, but you did the work. That's active range of motion. That is not what we're doing here. This says passive range of motion. If your patient can move the extremity themselves, it is always best that they do so. Your care plan would say active range of motion. We would prompt the patient, make sure they're doing it right, give them, kind of that encouragement. But your patient's ultimately going to do the work because they get more benefit out of it when they do the work. More muscle engagement. But sometimes your patients can't do the work, and that's where we come in. That is passive range of motion. This patient can't do the work, so I'm going to have to. I am going to extend an extremity. Now, when I asked you to extend your arm above your head, this is what you did, right? You went straight up. So extension is straightening a body part. Flexion is bending a body part. Now this doesn't look bent, but we're talking about the shoulder here. This is bent. If you look at the shoulder, this is bent. If you look at the shoulder, this is straight. So this is extension. This is flexion. You can see it easier on the elbow. This is extension, elbow is straight. This is flexion, elbow is bent, right? So your joints can move in a lot of different directions, but not all joints can move in every direction. Like my elbow only goes in one direction, up and down. Flexion, extension, that is it. If you get an elbow to do something else, you broke it. Don't break elbows. But your wrist, however, can move in a lot of different directions. Your wrist can move up and down, just like your elbow, but your wrist can also go side to side and around. Side to side is abduction, adduction. Around is rotation. So how would we know which exercises to do on which joints? The care plan. Our care plan is going to tell us which joint, which exercise, and how many times to do it. So it's like a recipe. Follow the recipe, your cake will come out just fine. So in this case, our recipe tells us right hip, knee, and ankle, flexion, extension, 3 repetitions. Hip and knee are going to be exercised together. It's a 2-for-1 exercise. It's the only time we exercise joints together, hip and knee. Now, the reason for that has everything to do with a nerve running through your back and down your leg called the sciatic nerve. I'm going to show you that in just a second. So in order to exercise both the hip and knee together, it looks like this. Your patient is laying down and you bend that knee up toward their chest and back down to the bed. And when you bend that knee up to the chest, do you see how the hip is bent? Do you see how the knee is bent? So we're exercising both joints with one motion. This looks like your patient is climbing stairs or marching in place. Okay, good. What you don't want to do, is this. We don't do a straight leg raise. We have down the back, down your back is your spinal cord, and it branches off right about your hip, upper butt area, branches off into 2 nerves called the sciatic nerves. Those run down each of your legs, and we have to be able to get signals to our toes. That's what they do. These nerves are already pretty tight. So think of a rubber band, okay? These nerves are pretty tight. Now, when we try to bring one leg straight up, it stretches that nerve. And as we get older, we get less bendy. Remember, we talked about that a little bit. We get less bendy, less flexible. And especially with older people, this action, this straight leg raise, this stretching of that sciatic nerve can irritate the nerve, cause inflammation, and it may take months for that pain to subside. Not days, not weeks, months. And it's extremely painful. Anybody ever have a toothache where you've got like the nerve, you know, that really, you can't get away from it? It's like the pain is always there. That's what sciatica feels like. Your patient's not going to be able to really focus on anything because the pain is always there and it's very irritating. We don't want to do that to our patient. By bending the knee at the same time, it's like a rubber band. You're kind of keeping some laxity in that nerve as we're lifting the leg. It doesn't pull it straight. Make sense? Okay. So that's the hip and knee. We exercise those together. Bend the knee up to the chest and back down to the bed. We're going to do that 3 times because our care plan told us to. Then we're going to move on to the ankle. Oh, you want to bend the foot forward and back, like they're stepping on a gas pedal, and then the toes back toward the head. And this is going to provide a little stretch. Okay, a little stretch. So when you do that, you don't want the heel to scrape along the sheet as you're bending forward and back. What you want to do is lift that heel off of the bed a little bit as you bend forward and back so that heel doesn't scrape on the sheets. Because as we age, our skin gets much thinner and is prone to injury much more. So you don't want that scraping action against the sheets because it can be like she was saying, I can't remember her name. But the lady here, the last class, she said that, she just grabbed her mom's hand and caused a skin tear. Same thing. It just that scraping motion can actually cause a skin tear, especially now we're going to put a lot of things together here. Okay. So remember we talked about pressure. Okay. When you lay down in bed, kind of our most common position is on our back when we first lay down, on our back. Heels would then be on the mattress. That's going to interrupt blood supply to that area. We've got pressure there. Now, so we have an area with a little less blood flow, which means that the tissue is going to become affected. Now, when we bend that foot forward and back and that affected tissue gets scraped, it can just come apart. Make sense? Okay. So just elevate that heel just off the bed. It doesn't have to be like we're not lifting it straight up, just a little bit off the bed so that that heel doesn't scrape. Okay. Good. So we're going to follow our care plan. Our care plan tells us which exercises, which body part, and how many repetitions. Just follow that. Questions on this? Questions on this? All right, so we're going to walk through it verbally, and then I'll show you the video. We're going to do our opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do range of motion on your hip, knee, and ankle. Is that okay? Close curtain, wash hands. We'll evaluate if we need gloves. I'm going to support the leg from underneath, bringing the knee up to the chest and back down to the bed 3 times. I'm going to lift the foot up. Where am I? So up to the chest and back to the bed 3 times. Remember, flexion extension is up, down. Abduction, adduction is side to side. Rotation is around. These are the only 3 motions that a CNA can do. Our care plan for this skill just said flexion extension. That's the only one we're doing. Other 2s don't count for this patient. We're going to ask if they have any pain as we do this. We want to monitor for pain. Look at their face. Are they wincing? Are they grimacing? Are they turning away? Are they stiffening up? Stiffening up means something is wrong. Always go below the level of the pain. So if they stiffen up, the next one, go below that stiffening. And then let the nurse know, hey, when I was doing range of motion, they really stiffened up when they got about halfway through. Let the nurse figure out what the problem is there. Might be a new problem that needs to be dealt with. Okay. Sorry, let me go back here. Then you're going to move on to the ankle. You're going to lift the foot off the bed, push the ankle or the foot forward and back, just a gentle stretch 3 times. Again, monitor for pain. And then when you're done, you're going to do your closing. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine? Environment is clean. Bed is in the low position. You're in the middle of the bed. Here's your call light. Open the curtain. Clean my hands. This does not require documentation. So I'm going to review the care plan and then say my skill is done. Good? Good.
Can you add the shoulder?
You can. So,
What's the difference between that and
okay. So great question. And it kind of looks the same in a way. Let me show you. So when you abduct a child, you take it away from its family. Don't do that. That's bad. Okay. So let's review flexion extension here real quick so I can show you. So flexion extension, if I extend my arm up, notice where my hand is, okay? And if I bring my arm back down, this is all in front of my body. And I was very intentional when I told you guys what to do in front of the body, okay? Now, abduction, adduction is to the side of the body. So when you abduct a child, you take it away from its family. When you abduct a joint, you take it away from its family. But if you notice, my hand ended up at the same place, but facing a different direction. So this looks more like making a snow angel, okay, out to the side and back in. This is flexion extension. This is abduction, adduction. Hand ends up in the same place for both, but facing a different direction, and it works different muscle groups. Even though the hand ends up in the same place, and you would think, okay, it's all working these, but it's different muscle groups. Does that make sense? So that would be the shoulder. Shoulder. Right. So your elbow cannot abduct and add. Elbow only goes one direction. This is it. Right. But your wrist can. So if you hold the wrist, you can't really do it to yourself very effectively. But if you hold your wrist, hold somebody's wrist, and your other hand is here, you can actually, holding the wrist stationary, you can, with the hand, you can turn it in and out, right? So that's an abduction, adduction. You can abduct and adduct a hip. You can bring the leg out to the side and back in. You cannot on the knee. Knee only goes up and down. That's it. But you can on the ankle. So do we have to know what body parts can move in what directions? We do, because we want to make sure that we're not putting our patients in jeopardy, right? So you want to know that your elbow can't do anything but flexion extension. Knee, same thing, so that you know how to perform these skills properly. Would we be responsible for figuring out what exercises to do with each joints? No. In fact, we have a whole department geared toward this. Anybody know what that department is? Exercises to improve function? Physical therapy. Yeah, we call it the torture chamber. Anybody know how much education a physical therapist has to have? It's a doctorate degree. Used to be a master's degree up until about 8 to 10 years ago, and then they made it a doctorate degree. So these are actual doctors. That's 10 to 12 years of education to learn how to move body parts to improve function. 10 to 12 years of education to learn how to do that. How long are we here? Yeah, 4 weeks. That cannot be us. Not even close. Now, physical therapy assistants, those are the ones, the physical therapists decide what to do. The physical therapy assistants are the ones that actually do that work. That's a 2-year degree. That's an associate's degree. How long are we here? A month. That's not us, right? So we are performing exercises on healthier body parts to keep them at their current level of function. We're not working on the stroke side. That's physical therapy, not us. We are working on the non-stroke side so that while physical therapy is concentrating over here, getting this as rehabilitated as they can, the patient's not really doing a whole lot over here. They're not moving it much because physical therapy is working over here and they got you to do everything else for them. So what do you think is going to happen to this shoulder if it doesn't move in, I don't know, 2-3 months? That's right. We lose muscle tone, which is atrophy, and we lose range of motion, which actually is called a frozen shoulder. That's the technical term for it. You lose function. So at the end of all this, your patient is a little bit better on this side because physical therapy worked on it, but this side is way worse. Did we really help them? No, we really didn't. So range of motion by CNAs is done specifically to retain function. Physical therapy does exercises to regain function. Two totally separate goals. Does that make sense? And when you start thinking about doing exercises to regain anything, stop, not your department. You can't bill for that. Okay, good? Make sense? All right, Jake, can you throw up range of motion, hip, knee, and ankle, please?
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I need to do some exercises on your right hip, knee, and ankle. Is that okay?
Yes.
Okay, I'm going to close your curtain. Let me go wash my hands, and I'll be right back. Okay, after washing my hands, we're ready to get started. The first exercise I'm going to do is bring your knee up to your chest and back down to the bed. I'll do all the work. All you have to do is let me know if there's any pain or discomfort. We're going to provide 2 points of support, one under the knee and one under the heel. And we're going to lift up and all the way back to the bed. Feel okay?
Yes.
Any pain?
No.
We're going to do it again. Up and all the way back. And one more. Up and all the way back. Feel okay?
Yes.
Okay, now I'm going to work on the ankle. I'm going to lift your leg off the bed just a little bit, and then I'm going to bend your foot forward and back. You should feel a little stretch. Please let me know if there's any pain.
Okay.
So I'm going to lift under the ankle. We're going to bend the foot forward and then back. Feel okay?
Yes.
We're going to go forward and back. Feel okay?
Yes.
One more, forward and back. Good?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Are you comfortable?
Yes, ma'am.
Environment is clean. Bed is in the low position. Here's the call light. If you need anything at all, just press the red button and we'll be happy to come help. I'm going to open the curtain and go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. All right, any questions on range of motion, hip, knee, and ankle? I would want that skill during the exam. I would. It's an easy skill. It's a quick skill. It doesn't really require much. No supplies. It's a cool skill. There are 2 more range of motions that we will learn. That is the hardest one. That's the hardest one. We already did shoulder. Shoulder is flexion, extension, and abduction, adduction. I showed you that, right? So figure out which side, according to the care plan. Flexion, extension is up, down 3 times. Abduction, adduction is side to side 3 times. That's it. We also did range of motion of the elbow and wrist. Elbow only goes in one direction, up, down 3 times. Wrist goes up, down 3 times. That's the whole skill. Put an opening in front and a closing behind. So, but we will show you the videos for range of motion, shoulder, and elbow and wrist in 2 upcoming episodes. Okay. Any questions on that? Okay. So we're going to move on to denture care. Do you guys understand that every patient is going to be a little bit different? Have I kind of explained that to you? That no two patients are going to be exactly the same. No two care plans are exactly the same. And if you change any one little piece of the puzzle, you change the whole care plan, right? Because we have to account for that. It's important that you understand that, because unfortunately, as CNAs, you only have this much information to work off of. That's it. Nurses have about this much information to work off of. So they're looking at all of the options, where CNAs are only looking at a few small options. So it's important that you understand we can't change the care plan. If we can't follow the care plan, we let the nurse know that we can't follow the care plan and why, and they'll figure out what accommodations need to be made. Okay, good. I saw a headline. Wanted to tell you when we're looking at Pulse. This I actually saw this on Facebook today, and it's hilarious how they try to make these headlines, clickbait, so that you click on the article or whatever it is they're trying to get you to click on. Well, this one headline just had me scratching my head. It says, first man to live without a heartbeat or pulse. Okay. Well, if they don't have a heartbeat, they certainly don't have a pulse. But the way it was worded, it's like those are two totally separate things. They're not. So it's funny how people perceive healthcare, that you can use really big words and it confuses people. So when we're talking to patients, try to put everything in terms that they can understand. So when I'm doing range of motion, I'm not going to say I'm going to do flexion extension of your shoulder, because your patient will stiffen up. They don't know what that means. They're afraid of it. Is that going to hurt? That's the first thing they're going to think is that going to hurt? Because remember, healthcare usually hurts. It's a fact of life. CNAs don't hurt patients, but healthcare in general often hurts, and your patient's going to be afraid of you. If you say, I'm going to extend your arm above your head like you're asking a question, your patient will go, oh, I can do that. I'm going to bend your knee up to your chest and back down to the bed like you're climbing stairs. Oh, I know what that is. That's okay. That doesn't hurt. Your patient will visibly relax if you explain these motions in terms that they can understand. But if you walk in and say, I'm going to do abduction, adduction on your hip, they're going to go, no, you're not. I don't know what that is. Okay. A lot of times CNAs try to use medical terminology to make themselves feel more important. Your patient is not going to appreciate that. Your patient will appreciate it if you are more on their level. Does that make sense? Be careful there. Question I got from that same person that I said, gave me a whole bunch of questions. That was one of the questions she asked is, I noticed on the game show, she went back and watched a whole bunch of my old episodes of the game show, and she said, I noticed you don't have medical terminology on there. Why? And my answer was, because it's not on the state exam. If you look at the test plan, there is no category for medical terminology. They're not going to ask you, what is abduction? It's not going to be a test question. But you sometimes have to know medical terminology or medical abbreviations to be able to answer the question. Even though it's not going to ask you what is abduction, you kind of have to have an idea of what it is, because the question might say, you are assigned to perform flexion extension and abduction adduction on the right hip, knee, and ankle. Which of the following actions would be correct? Bend the knee up to the chest and back to the bed, and then bring the leg out to the side and back in. B would be roll the patient's leg in and out. C would be walk the patient to the bathroom. And D would be perform a straight leg raise. So you would need to know a little bit about what flexion, extension, and abduction, adduction was to answer the question. But they're not going to come right out and ask you, what is abduction, adduction? Does that make sense? In your skills book, if you can go to page 131 for a moment, I want to talk to you guys about this a little bit. So page 131 is going to talk to you about medical abbreviations. 132 and 133 is an activity related to this. But as a CNA, you are going to be around medical abbreviations, and it's important that you know a few right off the bat. So on page 132, anything that is highlighted in gray is something that you do need to know for the exam, because these might be on the exam. But again, they're not going to ask you, what is NPO? They might say your patient is NPO prior to a procedure. Which of the following snack is appropriate for this patient? And it'll give you 4 options. One of them will be no snack. So you have to know a little bit about what NPO is to be able to answer the question. Make sense? There are a few there, but I want to go over the ones at the top, the frequencies, because this really messes students up. What you have to understand is for most medical abbreviations, it's not abbreviated English. Like if you try to make NPO mean something in English, you're going to come up short because it doesn't make any sense. It's not abbreviated English. It's abbreviated Latin, because Latin is the language of science and medicine. And most people way back when medicine was first being discovered and created, people had to be able to communicate with other medical scientists in other countries. And the one language that everybody learned in university was Latin. So most medical discoveries were always written about in Latin. And that's why we get a lot of these medical abbreviations that just don't make sense in English. So NPO is an abbreviated Latin term that means nothing by mouth. But if you look at frequency, this really gets confusing if you don't understand that. QD, how in the world does that mean every day? Well, Q stands for, and I'm going to butcher this. Those of you who are playing along online, please do not send me hate mail about my Latin. I'm not a Latin speaker, but quaque or something like that means every. So QD is every day. Q2H would mean every 2 hours or horas. QOD would be every other day. But then you get to the BID, TID situation. BID, again, Latin. B stands for bi. How many wheels does a bicycle have? 2. So BID is 2 times in a day, twice a day. TID, how many wheels does a tricycle have? 3. TID is 3 times in a day. Now, the one that'll really throw you is QHS. It means every bedtime. But in Latin, it's every hour of sleep or insomnia. That's how they say bedtime. It's the hour that you sleep. So QHS is every bedtime. Those are the ones that you really need to know for frequency. Okay. Good. And that's going to directly relate to range of motion, by the way, because most of your range of motion orders out there in a clinical setting will be perform ROM to the LLE BID. Now that sounds very, oh my gosh, what does that even mean? Well, ROM is range of motion. That's abbreviated English. LLE, left lower extremity. That's abbreviated English. BID, 2 times in a day, but it's abbreviated Latin. So it can get a little confusing. Okay. If you do not know what a medical abbreviation is, ask. Don't make it up. Don't assume. Don't try to work it out in your own head. Ask somebody. And I'll give you a good example of this. When we owned the scrub shop in town, we had a woman come in. I owned that store for 20 years. And I would work at the register every so often. And we had a woman come in from Tampa. And she says, "You still teach the classes?" I said, "Yes." She says, "Boy, do I have a story for you." So she worked in the cath, we're going to call her Kathy. She worked in the cardiac cath lab. So this is where they do cardiac caths when somebody has a suspected blockage, has had a heart attack or something like that. So she goes upstairs. It's like not even 5 o'clock in the morning to get the first patient for the first procedure. Doctors in the cardiac cath lab scrubbing up, getting ready. She goes upstairs to get the patient sitting up in bed eating. And Kathy says, "Why are you eating? You're about to have a cardiac cath. You're supposed to be NPO." And the patient says, "I know. It's so weird because I didn't think I was supposed to have anything to eat or drink, but the nurse came in and said I had to have this before I went down." Kathy goes, "What?" So she goes out to find the nurse. And she asked the nurse, "Hey, this patient is supposed to have a cardiac cath. Why are they eating?" And the nurse says, "Oh, I don't know. That patient has a student nurse. Go ask the student nurse." So Kathy goes and finds a student nurse. And this is the conversation as it was relayed to me. Okay. Kathy asks the student nurse, "Why is that patient eating?" Student nurse says, "Because they're NPO." Kathy says, "Wait, I know they're NPO. They're about to have a procedure. Why are they eating?" And the student nurse doubles down and says, "Because they're NPO." Kathy says, "Hold up. What do you think NPO means?" Student nurse says, "Nanas, pineapples, and oranges. I went to dietary and had the tray made special." Kathy about lost it. "Why do you think that NPO means nanas, pineapples, and oranges?" Student nurse says, "Well, what else could it mean?" It's a fruit tray, to clean them out before the procedure. So first of all, nanas is not even a word. NPO is not abbreviated English. And most importantly, Uncle Google is riding around in your pocket and is your friend. If you didn't know what NPO meant, a quick Google search would probably put you on the right path. But if you don't know what something means, you cannot simply make it up. You have to find out. What the student nurse should have done is gone to their preceptor and said, "Hey, I don't know what NPO means. What does this mean? What am I supposed to do here?" But she didn't want to look stupid. So she made something up and really looked stupid. Now I've got a patient that can't have their cardiac cath done. That means that they might have a fatal heart attack today that could have been prevented. There's a doctor in the cath lab, scrubbed in, ready for the procedure, that can't work. Non-billable time. Do you think that they just want to sit in the corner and play Candy Crush? They want to make money. They're there to make money. And even worse, when they set up the cardiac cath room, it is for that specific patient. Everything in there is selected based on the patient's situation, their EKG, their body size, all of that. So everything in there has to be scrapped. All because one student did not know what an abbreviation meant and made it up. It's a true story, guys. Yeah, and the patient gets the bill. Yeah. So when it comes to medical abbreviations, medical terminology, if you don't know what it means, you have to ask. Don't just make it up. Good? I can't even imagine. I'm really impressed that Kathy didn't hurt that student nurse. I mean, that's just crazy. But this can help you too. If you learn how to use these medical abbreviations and this medical terminology, it can help you. If you go to page 115, let's talk about report. So page 115 talks to you about a team's report. Team's report is something that CNAs can do when you're going off of a shift and you need to pass information about your patients to the oncoming shift, or when you're coming on to shift and you need to receive information about your patients. So there's always a point in time where one shift is leaving and one shift is coming in, and information is going to be passed, and we call that a shift report. It depends on your setting, how this is going to be accomplished. If you're in a hospital setting, a lot of times it's just you and another CNA kind of off in a corner, sharing information. If you're in a mental health setting, it might be an entire team around a table where everybody's, putting out information, the nurses, the doctors, the therapists, the staff members, so that everybody has all the information. If you're in a long-term care setting like a nursing home and your patients hardly ever change, you might actually get a printed report sheet, which is what you see at the bottom of page 151 there, or 115, I'm sorry, 115, where you see the room number, who the patient is, a 42-year-old white female or something like that, what you need to know about each one of their activities of daily living. Now, if you don't have anything like this and you need to collect information or give information, doing it in a very organized manner is helpful. That way nothing gets missed. And that's what that Teams report does. TEAMS. T is for toileting. It's the first thing you need to know about every patient, because I guarantee you somebody's going to hit that call light during shift report and have to go. First thing you need to know about every patient, how do they toilet? Do they go by themselves? We like those people. Go. I don't want to be involved. You guys are all toileting ad lib. When you need to go, you get up and go. I'm not involved. Some people will be toileting with assist. They go to the toilet, but they need some help. Some people can't make it to the toilet. We bring a toilet to the side of the bed, a portable one called a bedside commode. They might use it with or without assistance. Some people will need a bedpan. Some people have a catheter, and some people are incontinent. You need to know who's who. So that's first thing we need to know about your patient is how they toilet. That's why everything starts with T. Next thing we need to know is how do they eat, because every patient is going to need to eat on your shift, or you're going to need to know that they can't eat, and that's probably more important actually. And this is going to encompass, are they fed? Do they have special diets? Do their liquids need to be thickened? Do they need their food pureed? Are we supposed to encourage snacks? Are we supposed to encourage fluids or restrict fluids? There's lots of things that go into eating. It's not like you deciding Taco Bell or McDonald's. Okay. There's a lot of things that affect, and we're going to talk about that more next class. So that's the E. So T is toileting, E is eating. A is for all the other ADLs. Dressing, bathing, grooming. What do we need to help them with? Do they brush their own teeth? Do we have to do denture care on them, or do they do that themselves? ADLs. What do we need to help them with? Then there's M for mobility. Now, mobility is a special category all by itself, because this is probably the most important category for you to know. Toileting is important. Eating is important. ADLs is important. But mobility is really important, because you need to know, does the head of the bed need to remain flat for this patient for this shift? Are they allowed to get out of bed? Should we turn them every 2 hours? Remember, if we don't turn somebody every 2 hours, they can end up with bed sores. Are we using a wheelchair, a walker, a gait belt when we're getting them out of bed? What do I need to know about their mobility? Because if that call light goes off and they have to toilet, you can't take care of the toileting until you know about the mobility. Good. So mobility is always a special category by itself. Then you have S for special. This is everything else not covered by those 5 topics. Are you noticing that this kind of covers everything we do? Every skill that we learn in here, if you look down, all of those skills falls into one of those categories. Toileting, that's bedpan, pericare, catheter care. Eating, we're going to cover that. ADLs, that's bathing, dressing, grooming. We have a ton of those. Mobility, that's your range of motion, ambulate, turning a patient. And special are vital signs, things we should watch for. Something else we need to know. They fell last night. Anything other. So Teams report is CNA all wrapped up. Everything you need to know about that patient. And if you do it in this manner, in this method, it makes shift handoffs so easy. All right, bed A, toilet self ad lib, eats a normal diet, takes care of all of their own ADLs. They're fully mobile on mobility, but they're here because they have a super high blood pressure, so their vital signs are every 4 hours. Please report all blood pressures to the nurse. See how quick that report is? Okay. Bed 2, this is an 89-year-old male. He had a stroke 3 weeks ago. He's got right-sided paralysis. He has difficulty swallowing, so he is bedpan and urinal for toileting. He is a feed. You have to feed him, but all foods are soft and all liquids are thickened. ADLs, you need to help with everything. Make sure everything is on his stronger side. Mobility, he is bedbound. He cannot get up out of bed because physical therapy has not been in yet. And special, he's vital signs every 4 hours as well, and report any worsening of symptoms. Again, you see how quick that report was? It keeps you on track. Otherwise, you're going to be like, yeah, this guy had a stroke like 2 weeks ago. And let's see, it's disorganized. Okay. So Teams report can help keep you on a good path. Bless you. All right. So denture care is a skill that would fall under ADLs. So let's talk about denture care. We know mouth care. We've learned mouth care. Denture care is mouth care with an extra step. We're going to do mouth care because if the dentures came out, there's still stuff in there. There's denture paste, there's food particles. You can't just clean the dentures and hope for the best on the mouth. We got to clean that too. So denture care is mouth care with an extra step. So we're going to talk a little bit about this. Here's all the principles involved. We're going to follow our care plan, do our opening. We will need gloves because body fluids. You're going to need a barrier for this. We're going to use some linens during this skill. You're going to clean the basin, and we're going to do our closing. So we have to learn a little bit about denture care itself to learn how to do this skill. But nothing as far as principles go. We know all the principles involved. So if you go to page 97, at the top of the page, you'll see our care plan. Care plan says a resident with dentures is sitting at an overbed table with their dentures in a denture cup. Sitting at an overbed table, dentures in a denture cup. This is how the patient will be positioned for the state exam. You're not taking dentures out. That is not a CNA task. You do not put dentures in. That is not a CNA task. Patients have to be able to take their own dentures out and put their own dentures in order to keep using their dentures. If they can't, they don't use their dentures. We puree their food, chop it up super fine so they don't have to chew. But you do not take dentures out. And the reason is you have a very high likelihood of dislocating that lower jaw when you take somebody else's dentures out. Dentures are held in by suction and denture paste, which is gummy, sticky, holds dentures in place. So your patient can eat steak and corn on the cob and, other chewy type foods. Those dentures have to stick. If you put your hands in somebody's mouth to get those dentures off of their lower jaw, you have to press down with these knuckles on the jaw for these fingertips to pop up. When you press down on that lower jaw with these joints, right? If I'm going to press down to pop something up, you can dislocate that lower jaw. Now, if I'm doing that on myself, I'll never dislocate my jaw because it's a different angle. I'm going in like this to pop that bottom up, and I'll never put enough pressure on my lower jaw to dislocate it. But if I put my hands in your mouth, it's a different angle, different pressure point. You definitely don't want to put dentures in because when you put dentures in somebody's mouth, they will bite down to seat those dentures. It's an unconscious motion. They won't even know they're doing it. It's just a reflex. Put dentures in somebody's mouth, they bite down. If you put somebody's dentures in their mouth, where are your fingers going to be? In their mouth while they're biting down. And it's very easy to get bit. Your patient doesn't mean to do it. It's a reflex action. But the problem is those dentures aren't fully seated, so they have no idea how much pressure they're putting down. And they can absolutely break your skin or your finger. So don't put dentures in. Don't take them out. Not your job. Patient has to do that, which is why for the test, our care plan says our patient's sitting in a chair at an overbed table, and their dentures are in a denture cup. So our job for this skill, according to our care plan, is to clean the dentures and the mouth those dentures came out of. We're going to leave the dentures in the cup, put them in an accessible place for your patient to get later when they want to put their own dentures in. And we know that because our care plan says a resident's denture needs to be brushed with toothpaste and the resident needs mouth care. The denture is stored in a denture cup after cleaning. The resident is not able to provide their own mouth or denture care. If your patient can take care of their own dentures, they will. They are not going to want you messing with them. Dentures, a full set of dentures runs about $5,000 to $6,000. If you've got something that's worth in your house that's worth $5,000 to $6,000, you going to let any old stranger that you don't know off the street mess with it? Probably not. So your patients are not going to let you work with their dentures unless they really have no other choice because they don't trust you. And unfortunately, you have a pretty high likelihood of breaking their dentures. A lot of CNAs break dentures because they don't know what they're doing. Now I'm going to give you some strategies to keep that from happening. And that's really what this test is all about, is can you protect the dentures? Keep them from breaking. All right. So let's talk about dentures. There's a couple different kinds of dentures. Most people don't know that. Most people, when you think about dentures, we think about this. This is a full plate. This basically replaces all of the patient's teeth. This is a top denture. This part fits against the upper palate. A bottom denture doesn't have this middle piece because you got to have a place for your tongue to rest. So bottom plate just has a horseshoe shape. Top plate will have a palate. This is a full plate. All teeth have been replaced. But this isn't the only type of denture because if your patient still has some healthy teeth, we're not going to pull those. We're going to leave healthy teeth alone. And in that case, we would give them a partial. This is a partial. This is a bottom plate. See how it's a horseshoe shape? There's no palate in between. So this is a bottom plate. And we've replaced the teeth that have been pulled, and we've left gaps for teeth that remain. So we have a full plate and we have a partial. Then you've got another type of denture, which I don't have a example of, called a bridge. It's just a little piece of denture. It usually attaches to teeth on both sides with a hook or a wire to keep it in place. Bridges now are mostly implanted. They don't come off. So bridges are a little bit different now than they used to be. But if you're working with an older client, they may have an old bridge that they still use. So you need to be aware of it. We clean them all the same way. Doesn't matter whether it's a full plate, a partial, or a bridge. It's all going to be cleaned the same way. But you need to know that there are some differences there. Okay. So we need 2 sets of gloves for this. This is probably the hardest part of denture care, is that we need 2 sets of gloves. And that means that there's going to come a point at some point in the skill where you're going to have to change from one set of gloves to the other. When does that happen? What is the crossover point? What happens if I touch this with those gloves? Students get all tangled up in this. I'm going to make this super simple. They don't care. Except, here's your 2 rules. If you are going to touch the actual dentures, you need gloves on. If I'm going to touch dentures, I need gloves. Once I'm no longer touching the dentures, I don't need gloves. They don't care when you take them off. If you're going to put your hands in somebody's mouth, you need gloves on. After you're done in somebody's mouth, you don't need gloves. They don't care when you take them off. Okay. So if you have gloves on when you're touching the dentures and when you're in somebody's mouth, that's all they're grading you on. All right. The crossover point, they don't care. I'm going to teach you the right way to do it. Bless you. I'm going to teach you the right way to do it so that you have that knowledge, but I need you to kind of relax a little bit when it comes to the test. Everybody good with that? Okay. All right. So if you were the patient, bless you, if you were the patient, would you want those gloves that had cleaned dentures in your mouth? Or would you want a clean set? I'd want a clean set. Yeah. So that's why we require 2 sets of gloves. 1 set will clean the dentures. Once the dentures are put away, they don't care when you take them off. A brand new set to clean the teeth. They don't care when you put them on or take them off, as long as you have clean denture or clean gloves on when you're in the mouth. Good? Good. Okay. We're going to get to the actual changeover point in just a few minutes. All right. So there's 2 ways to clean dentures. And generally speaking, the way that you clean them for the test is not the way you're going to clean them in a clinical setting. Because people with dentures, the people that make the dentures, you know, the denture care specialists, the prosthetics, oral prosthetic makers, people who made these things, they don't want you to use toothpaste on them because toothpaste is abrasive. Toothpaste has these little micro particles that scrub, and dentures are not made out of the same material as your teeth. So if your teeth are they're different, they're living, there's a biofilm there's some protective mechanisms that we don't have on dentures. So if you use that toothpaste, that abrasive toothpaste on dentures, and we scratch the dentures, now we've got little areas for bacteria to hide, little micro cracks, and it actually reduces the amount of time that your dentures can be used. It shortens their lifespan. So most people will say, don't use toothpaste on my dentures. Put them in a cup with the little fizzy tablets, you know, the Polydent or Effordent or whatever, the denture cleaning tablets, because those little fizzies actually break down the food particles and the denture paste, and it cleans the dentures much more effectively without it being abrasive. So there's two ways to do this. You clean with denture cleaning tablets or with toothpaste. How do we know which one we're going to use? The care plan, and our care plan here tells us to use toothpaste. So we're going to follow our care plan. All right, Doreen says, good morning. Thanks for your videos. I passed my exam last Wednesday, the 17th of September. Congratulations. Great job, Doreen. All right, so we're just going to follow our care plan when it comes to how to clean the dentures. Jake, can you take that down for me? Thank you. Now, we're going to use a special brush. You won't always have this, but you will for the test. This is a denture brush, and it's just a toothbrush. It's a double-sided toothbrush, but that's really all it is. But one side is narrow and one side is bigger. This looks like a toothbrush head, so we're going to use it on the teeth part of the dentures. This side is narrower, and it is designed to fit in that channel. This doesn't fit as well in the channel. This narrower, because it's pointed, it's tapered down, it fits in that channel very well. So you can clean that channel easily. And then this side is used to clean the teeth. So a denture brush can be used if your patient has one. For the test, you will have a denture brush. Use it. But if not, you can just use a regular toothbrush. It's fine. This is what we're going to use in the patient's mouth. This is called a toothed or an oral swab. It's soft, it's spongy, and more importantly, it's four-sided. When you're trying to clean the patient's mouth, their gums, if they have teeth in there, whatever's in there, it's got denture paste and food particles. That denture paste is stringy and sticky. If you try to use a brush to get that stringy, sticky gunk off of their gums, that brush is going to get all gunked up. It's not going to be as effective. Where when you use this, you're going to swipe the denture paste away and then turn it. Now we've got a new area to work with. And we can swipe and turn it, and swipe and turn it. Okay, so we can use it like a toothbrush. We're going to dunk it in water, put some toothpaste on it, and use it like a toothbrush. But when you're trying to get denture paste out of a patient's mouth, this is way more effective than a brush with bristles. Good? Does that make sense? The other thing is this is disposable, which to me is a definite plus, because I don't want to stand there at the sink for 5 minutes trying to get gunky denture paste out of a bristled brush. It's like trying to clean a paintbrush after you use it. It takes forever, right? This, use it, toss it. Makes life so much easier. So I'm going to pass these around so you guys can see the difference between a full plate, a partial, a denture brush, and a toothed.
So for the test, if we have to do this, it would just act as a gums and nothing.
So for the test, well, even in a clinical setting, if your patient has dentures, they might still have teeth, you know, if they have a partial. So for the test, you're going to be sitting at a table just like this, dentures in front of you. The person that's performing the skill, the CNA, is going to take the dentures to the sink, clean them, bring the denture cup back and put it on the table because our care plan told us to. And then they're going to clean your mouth using the sponge. And they're just going to brush like they would brush. Okay. So from a patient standpoint, this is no different than mouth care. No different than mouth care. From the patient point of view. You're not going to put dentures in. You're not going to take them out. You're not doing anything with the dentures. You're just letting them do mouth care on you. But they're going to do it with the sponge instead of the brush. Okay. So for mouth care, for denture care, we're going to wet the denture brush, put toothpaste on it, and we're just going to set it in our little basin just to hold it until we're ready to use it. We're going to get it prepped and ready. That's all that basin is going to do is hold that denture brush. And then we're going to take it over to the sink. Now we want a basin or something for that denture brush. You don't want to lay the brush on the side of the sink. That sink isn't clean. That's just gross. So that basin's just going to hold our brush until we're ready. When we're at the sink and ready to brush, we want to try to prevent these dentures from accidentally breaking. Guys, they're covered in saliva and food particles and denture paste. They're slippery. And then we're going to put them underwater and put some toothpaste on them. They're really slippery now. Chances are they're probably going to tumble out of your hands at some point. We don't want them to hit the sink because then they might break. So we're going to put a washcloth in the bottom of the sink. And that, if we can get it over the drain, even better, because it allows water to kind of pool up. That way, if the dentures fall, they hit the water and they slowly sink down. They don't crash onto the bottom of the sink. So washcloth in the bottom of the sink, definitely helpful. Great at checkpoint. If it's over the drain, even better. All right, we're going to use a paper towel to turn our water on, just like any other water skill. Use a paper towel to turn the water on, but this time we're going to use cold water, not warm. Heat coagulates proteins, and what that means is it's going to make all of the protein particles, your saliva, your food particles, that's stickier and harder to remove. You want cold water for this, not warm water. Make sure that the dentures are always in your hand. Don't set them down in the sink. Don't put them in, just in your hand. That's the safest place for dentures, is in your hand. When you're done cleaning them, hold them in your hand, rinse the cup out, dump it out. Yes, you need gloves for this. We're going to scrub all surfaces. Don't set them down anywhere. Make sure you're holding them in your hand. And then when you're done cleaning them, you're going to dump out the water in the cup. I'm holding my dentures. Dump out the water in the cup, rinse the cup, fill it up with water, and put your dentures directly in the denture cup. Dentures have to be stored in water. Now, I know I just passed around dentures in dry dentures and dry cups. Don't do that. If your dentures aren't in water, it makes them very brittle and likely to break. You don't want that material to dry out. It becomes brittle. I keep mine out of water because if I try to pass around water, it's going to get all over your books and everything, and people get upset. So mine are dry, but remember, at a clinical setting, dentures always need to be wet. Good? Good. All right. Once we have our clean dentures and our clean water in our denture cup, we're going to put the lid on and we're going to bring it over to our bedside table, but that cup is going to be wet. So I want to put a paper towel underneath as a coaster, because if you put a wet denture cup on a surface like this, it's like laminated wood, it's going to warp. And housekeeping is not going to be happy with you if you destroy their furniture. So we want to put a coaster or a paper towel underneath that cup just to dry it off a little bit, just to add a barrier. And we're going to put it on the bedside table for your patient to use whenever they're ready to put their dentures in. Not our job. That's on them. We're going to take that washcloth, wring it out, and put it directly in the hamper. We're done with that washcloth. Now, we're going to take our denture brush and our basin back over to our prep table. Remember, we've got a barrier on the table. We've got our cup of water and our toothpaste on the table and a towel. Good morning. So we're going to bring that basin and that denture brush back over to our table. We're going to take the denture brush out and put it on the side, on the barrier, because we're going to need that basin again. But this time, the basin is going to hold our toothette, that spongy swab. So we're going to wet our toothette, put some toothpaste on it, put it in the basin until we're ready to use it. I skipped a step. Sorry, guys. Let me go back here. Okay. I forgot to tell you. So when you brought that basin with that denture brush over to your table on the barrier, took the denture brush out and put it on the side, you have to remove your gloves then. We're done with dentures. Dentures are put away. We've got everything back here. We're ready to start mouth care. Take your gloves off. Okay. Are those gloves clean or dirty at this point? Yeah, they're dirty. Absolutely. So if our gloves are dirty and we're going to touch the toothette and the toothpaste and all, do we want to touch all that with dirty gloves? No. So take your gloves off before you start prepping for mouth care. So you'll put the spongy swab in the water to get it wet, put some toothpaste on it. We're going to lay it in the basin just to hold it for a second, get our towel on our patient, get them all ready to go. And then we're going to put our second set of gloves on. Then you're going to brush whatever they got. Just brush it. Nobody cares how. Top, bottom, front, back. Just brush it. No time requirement here. Just get all surfaces. And I would say out loud, I'm going to brush the top on the back, the bottom, the top on the other side, the bottom, the front. Talk it out so they know what you're doing there. But it can go literally that fast. Once you're done with that, you're going to throw the toothette away. And then you're going to help your patient rinse and let them spit as much as they need to. Once they've rinsed and spit, then you're going to dry off their mouth and clean your environment. So we're going to clean our basin just like we always clean the basin. We're going to put the toothpaste and everything back in the basin, put it in the drawer with our paper towels, take care of our barrier, do our closing. Thank you very much, Mr. Jones. Is there anything else I can get for you while I'm here? Would you like a magazine before I go? Here's your call light. Your environment's clean. Open the curtain. Go wash my hands. We don't have to document for this skill. So I'll go back and read that care plan, make sure I did everything correctly, and then say my skill is done. I'm going to tell you this is not a hard skill. You will make it a hard skill, but it is not a hard skill. What makes this skill hard is there's two parts to it. You're cleaning the dentures, you're cleaning the mouth, and you have to change gloves in between. That's what makes this hard. It's not a hard skill, but students tell me it's the hardest one for them to learn. Remember, pulse is the most failed skill because people don't follow the care plan. Denture care is the hardest one for people to learn because there's two parts to it. It's really not a hard skill, though. Good? Questions?
It's not really related to this skill, but will the dressing a patient, will that be on the test? That would be easy.
But it's on a mannequin.
And will the patient, will the mannequin already have clothes on?
They'll start out in a gown,
Okay.
and then you will dress them in socks, pants, and shirt. Yeah, that's a mannequin skill. So somebody in here last class asked me, about the evaluators kind of setting up the scene, right? We talked a little bit about that. So let's say that you have 3 skills. You have, hold on. Hold on. I have a point. I just have to find the right care plan set. Okay. So this is your care plan set. Okay. And your 3 skills are measure and record respirations, perform passive range of motion to hip, knee, and ankle, and dress a resident with a weak arm. Those are your 3 skills. Now, you need a patient to do those 3 skills on. You're going to be her patient for respirations and range of motion, hip, knee, and ankle. Those are both skills that require you laying flat in bed. So the evaluator will tell you, come over here. I want you to lay on top of the sheet in bed. Just lay down. You don't have to do anything, right? Be pleasant, cooperative, all of that, but just lay down. Now, you're going to do skill 1, which is respirations. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA. Well, your name, but I'm your CNA today. I'm here to take your vital signs. Is that okay? Or close curtain, wash hands. Alcohol pad on the tummy. Look at the clock. Pick a starting point. Start. Count the respirations till the second hand goes all the way around. Stop. Thank you very much, Miss Jones. Is there anything else I can get for you? Are you comfortable? Would you like a magazine before I go? Your environment's clean. Bed's in the low position. Open the curtain. Here's your call light. Go wash my hands. Document. Wash my hands again. And yes, you will wash your hands all 3 times. At that point, the evaluator is going to tell you, don't go anywhere. Stay where you are. They're going to tell you, you don't have to wash your hands anymore. You can proceed when you're ready. So skill 2 was range of motion, hip, knee, and ankle. So she's still in bed. So you're going to knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do some exercises on your right leg. Is that okay? You're going to say yes. Close curtain. You're going to say, I'm washing my hands. That's all you got to do. And then you're going to tell the patient, all right, Miss Jones, I'm going to do all the work. Just relax. Let me know if there's any pain. I'm going to bring your knee up to your chest and back down to the bed 3 times. I'm going to lift from below, knee to the chest, back to the bed. 1, 2, 3. I'm moving on to your ankle. I'm going to lift the foot and I'm going to bend the foot forward and back 3 times. So 1, 2, 3. Any pain? No. Good. All right. Foot's back on the bed. Here's your call light. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine? Bed's in the low position. Open the curtain. Say, I'm washing my hands now. Read the care plan. Don't need to make any corrections. My skill is done. Now, your 3rd skill is dressing a resident with a weak arm. We don't need you in bed. You're going to be told, get out of bed. In fact, chances are you tested first and they're going to tell you, go out to the waiting room. You probably won't even be in the room. But if for some reason you're testing first, you're just going to be told, go stand over there. And then they're going to put the mannequin in the bed, make sure the mannequin is in a gown, covered with a sheet. And then they're going to tell you, you can proceed whenever. Okay. Does that make sense? Do you guys kind of see how that whole thing flows? Chances are, though, because remember, the evaluators pair you up. So as the evaluator, I know what her 3 skills are. And if it works out, I'm going to have her do her skills first. That way, when we get to the mannequin skills, she's gone. She's out. And then all I have to do is deal with you, get you out. And then I can bring the next group in. Because where do I want to be? At home in my pool, drinking my margarita. I don't want to be here watching you guys. Absolutely not. We want to speed this thing along. You're standing in my way. This could be a 2 margarita day, right? So if you understand their mindset, you kind of understand how they put these processes in place to get everybody in and out quickly. Does that make sense? Good? Okay. Any questions on that? So I want to talk to you about this. This is a shameless plug. Just deal with me. We sell these practice kits. They're right up here on the back filing cabinet. I think I have one up here too. But in the practice kits are dentures. They're not real dentures. My mom makes these. Isn't she a great mom? I have the best mom. So she makes these. They have a groove, just like regular dentures. Just don't put them in your mouth. They won't work for you. But they have a groove, just like regular dentures. And you can use this to practice denture care. There's also the toothette. There's a denture brush. There's everything that you need to practice. Your bath basin, your emesis basin, gloves, chucks, orange sticks, emery boards, privacy blanket, gate belt, which we haven't gotten to yet, soap and lotion, everything you need to practice every single skill that we are learning in here. And it all comes in a carrying bag. We have 2 bags. We have a red bag, which you see up there, and we have the gray bag, tote bag. So when you guys are in this class, you guys, just you get this for $50. Everybody there, virtually, it's $64.99. I think it's still on sale. It was $69. It's normally $69.99, but I think I still have it on sale for $64.99. If you guys want to buy it and it's $69.99, send me an email and I'll give you a coupon code $64.99. But for you guys, you get $15 off of that. You get it for $50. And that's pretty much my cost, guys, for what you're getting. If you go to a medical supply store and try to buy each one of these pieces, it's well over $100. Gate belt alone on Amazon is right around $10 for a gate belt. So you're getting a great deal if you're going to practice this stuff at home, to be able to practice with the actual supplies you're going to be using on the exam. All right. Questions on that? All right, Jake, can you play Denture Care for me? And then after that, we're going to take our break, and then we're going to get into energy conservation, which is a super, super important skill to learn, or concept to understand when we're working with elderly patients. All right, Denture Care.
Hello.
Good afternoon, Mr. Jones. How are you?
I'm well. How are you?
Wonderful. My name is Patty. I'm your CNA today, and I would like to help take care of your dentures and perform mouth care. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. I'm going to take your dentures to the sink to clean them.
Okay.
I'll bring the denture cup to the sink on the paper towel. We're going to set it on the side of the sink and open it, placing the lid beside it, and then wash my hands. After washing my hands, I'll get my supplies. We're going to start with a barrier. This is going to provide a clean place to put our clean supplies. So we'll spread the barrier out on the table with the absorbent side facing up. And for this skill, I'll need a towel and a washcloth, being careful not to let the supplies touch my uniform. I'm just going to go gather the rest of your supplies. I need a toothette, a denture brush, and toothpaste, along with an emesis basin and a cup of water. We'll set these on the overbed table. And I need 2 sets of gloves. Okay, I'm going to get the denture brush ready. We're going to wet it and apply just a little bit of toothpaste on both sides. Set it in the emesis basin right now. I'm going to take the washcloth, a set of gloves, and the emesis basin holding the denture brush to the sink. Mr. Jones, I'll be right back. I'm ready to clean the dentures, so I'll set the prepared denture brush in the emesis basin on the side of the sink. I'm going to place the washcloth in the bottom of the sink over the drain and put my gloves on. I'll take a paper towel and turn cold water only on because we only wash dentures with cold water, and we're going to throw that paper towel away. Now I can clean the dentures. I'm going to take them out of the denture cup and rinse them off, making sure that I hold them over the sink at all times. I'll take the denture brush, and the small end of the denture brush is going to clean the groove part of the dentures. So we're going to clean that whole groove, all areas, and the palate. Then we'll turn the dentures over, being careful to hold them securely, and use the other side of the denture brush to clean the teeth part of the dentures. We want to make sure that we cover all surfaces. Making sure that we hold it securely. And then we can rinse the denture brush and put it back in the emesis basin for later use. We're going to rinse the dentures off, removing all of the toothpaste. We'll take the denture cup, dispose of the water, rinse it out, and fill it with cool, clean water, placing the dentures inside. Cover it with a lid. We can throw this away and get a clean paper towel to place underneath it. I can turn the faucet off, and we're going to go put this on the patient's bedside table. I'll place this denture cup on your bedside table over here for use later. Now I can remove the washcloth and place it in dirty linen. Now I'll bring the emesis basin holding the denture brush over to the overbed table and take the denture brush out and set it aside. Now I can remove my gloves. I'll throw these gloves away. Mr. Jones, I'd like to place this towel over your chest while I perform the mouth care portion of this skill. Is that okay?
Yes.
I'll get the toothette ready. We're going to get it wet. Put a little bit of toothpaste on it. And then hold it in the emesis basin while I put my gloves on. Okay, Mr. Jones, I'm going to brush all areas of your mouth, the top, the bottom, the front, the back. So I need you to open up wide for me, please. I'm going to start in the back, on the top, both sides, and then the bottom in the back, the front, and can you bring your teeth together? Thank you. Okay, thank you very much, and we'll rinse. Okay, pour the rest of the water in there. And just make sure that your mouth is nice and dry. Okay, I'm going to place this in dirty linen, clean my basin, and then clean my work environment. I'll be right back. We'll take the basin to the sink and dispose of the contents into the sink. We'll then rinse the basin and set the basin down in the sink. We'll use a paper towel to pick it up, a paper towel to dry the inside, a paper towel to dry the outside, and then one more for the drawer. On the way to the drawer, we'll pick up the denture brush and the toothpaste, placing them in the emesis basin for storage. The supplies away, we'll use a paper towel to open the drawer. We're going to put the basin, toothpaste, and denture brush in the drawer and then close it with the paper towels, and we can then throw the paper towels away. And now I'll dispose of all of my disposables. The cup, the wrapper, and the toothette, along with the barrier. These will go in trash. Now I can remove my gloves. We'll throw the gloves away. Thank you very much, Mr. Jones. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes.
Would you like a magazine before I go?
No, thank you.
Your environment is clean, your bed is in a low position, and you're safe. Let me give you your call light.
Okay.
Here's your call light. If you should need anything at all, just press that red button and we'll be happy to come back and help. I'm going to go open your curtain and wash my hands. After washing my hands, I'll review the care plan, make any corrections, and then tell the evaluator my skill is done. Forgot to give you your review sheets last class. So at the end of class today, you're going to get 2 review sheets. So just kind of be aware of that. But go ahead and go on break, and we will see you in 15. All right. Okay. Is that? Oh, okay. All right. So let's talk a little bit about energy conservation. Jake, did you, are we recording? Thank you. Okay. So energy conservation, this is something that you probably wouldn't think about too much unless somebody brings it to your attention. Have you guys ever seen a 2-year-old? I love 2-year-olds. 2 and 3-year-olds. Yeah, those are my favorite age. Because they're learning about individuality, right? They're learning that they are their own separate being. And anybody know what a favorite word is for 2? No, that's right. So no becomes their favorite word because they're just starting to learn that they have power, that words have power, and they're testing their limits, right? That's important for us to understand because anytime somebody feels like they don't have control, they will revert to no. And it's just a means of establishing control. And this is a lesson that we learn when we are super, super young. So remember, we talked about that. Memories that our brains make when our brains are young stick with us the longest. So if we have an older individual, let's say that we have an 82-year-old patient that feels like everything in their life is out of their control. They aren't allowed to go home. They had to sell their house. They had to sell their car. They had to give away their pet. Their spouse has died. Their health has taken a turn. They're now in our facility. Nothing in their life is going right. They do not feel they have control over anything. Do you know what they're going to say when you ask them, do you want whatever? They're going to say no, because it's the only way that they can feel like they have some control over something. And we have to understand the mindset there. If you don't understand that, or you just try to run right over them, you are going to end up with a very combative patient. Because patients have to feel that they are in control of something. Does that make sense? So a better choice when we have patients that are getting a little bit belligerent or unruly or saying no to everything is to give them limited choice. Would you like to have your shower now or after lunch? Notice no was not an option. It helps them feel like they have some say in something rather than just yes, no. Because if you just default to yes, no, no is going to be your answer. If you say, would you like your shower now or after lunch, it gives them at least a feeling that they might be in control of that decision. And it empowers the patient. And if you start communicating with that in mind, that choice beyond yes, no is always empowering. It'll set your communication up with your patients to be a little more positive. Does that make sense? Okay. So we understand that we learned this no as a means of regaining control, but that's not all that a 2 or 3-year-old learns. Or exhibits, I should say. Your energy level is the highest at 2 or 3 than it is any other time in your life. That is when you max out on your energy. And you know that by watching a 2 or 3-year-old run around, you automatically say, man, I wish I had that level of energy. Or if I could bottle that energy, I'd make a fortune. We've all had these thoughts or said these things. And it's true. That is the max amount of energy that you will ever have in your entire life is somewhere around 2 or 3 years old. And I'll prove it to you. Let's go out to about 12. Now, 12-year-olds still have tons and tons of energy. I mean, they can skateboard and play basketball and video game and tons of energy. But you put that 12-year-old in charge of that 2-year-old for one afternoon, who's going to win? 2-year-old every time. That 12-year-old will be like, Mom, can you make them take a nap? They're driving me nuts, right? The 12-year-old will give out before that 2-year-old. Your energy levels have declined just in that 10-year period. Have you ever tried to explain to a 2-year-old why you don't have the energy they do? Right? They're trying to get you to come play or do something with them. And you're like, oh, no, I don't want to. I just don't have the energy. Does a 2-year-old ever get it? You can explain it to you're blue in the face. They don't get it because they've never experienced anything else. They think everybody has exactly the same energy and mindset they do because they have no frame of reference. Keep that in mind. It's hard to understand something that you've never experienced. Okay. So we've got energy decline between 2 and 12. Let's go out another 10 years. Let's go out to 22. Now, 22-year-olds still have tons and tons of energy. They can shop till they drop and go out at night looking fabulous. It's great. 22-year-olds still have tons of energy, but you do not have the same energy level you had when you were 12. Your energy level has declined. Go out to 42. 42-year-olds are shopping till they drop, but that's at like 3 and we're not going out tonight. We're done. Energy levels decline. Now let's go out to 62. 62, we're thinking about retirement. We're putting our feet up for 10 minutes before we make dinner because energy. We don't really have the energy to do all of our normal daily household tasks that we need to do and work full time. So we're thinking about retirement. This is normal. Your energy levels decline throughout your lifespan. So now what do you think it's going to be like at 82? That's right. Because the energy levels decline and we have all of the problems with aging that we talked about last class. Remember, we talked about chapter 4 and our decrease in digestion and nutrient absorption, our shrinking of muscles, our lack of coordination, right? All of those things that happen as we age. So it sets us up when we're 82 to have very little energy and a whole lot of problems. Does that make sense? So when we go into that 82-year-old's room and we say, hey, Ida, do you want to shower today? And she says, oh, no, honey, I did not have the energy for that. Your response will probably be, oh, it's fine. I'll take care of it. All you got to do is sit there and I'll do the work. Don't worry about it. You are now trying to convince an 82-year-old that they have the same energy that you do, just like that 2-year-old did. And you don't get it because the 2-year-old didn't get it. That 2-year-old tried to convince you that you were just like them because they had no frame of reference. You will do the same thing to an older patient. You will try to convince them that they have the same energy level that you do because you have no frame of reference. Not until you become 82. Now, understand that this is a generalization. I have known people in their 90s that ran circles around a 40-year-old. Okay, I get it. This is a generalization. Not all older people are going to have energy deficits. But I want you to remember something. If someone is healthy and able-bodied, will they be using the services of a CNA? No, they're not going to need us. So the people that we are helping will fit into this category. That's why they need us. Does that make sense? If somebody's able to take care of their own needs, they don't need you. So it's important that we understand this. Energy levels decline throughout the lifespan. And you aren't going to understand your patient's lack of energy because you've never experienced that. But you've probably experienced little pieces of this. So let me explain this. Let me kind of lead you there, okay? If you use the phrase, if you've ever been too tired to fill in the blank, you understand aging. Have you ever been too tired to talk? Anybody? Have you ever been too tired to talk? On Mondays and Wednesdays, after I talk nonstop for four hours, when I go home, I don't want to talk. I am too tired to talk. It's a normal thing. If you've just spent all day out on the boat with your fishing buddies and you've talked nonstop, when you get home, you probably don't want to talk a whole lot. Right? So you probably have experienced that at some point. Have you ever been too tired to eat? Anybody ever been too tired to eat? Have you ever been too tired to take a shower, particularly when you're sick? Have you ever been too tired to get up and go somewhere? So you've experienced little pieces of this. Now put them all together. And that's pretty much what our patients experience when we're dealing with older patients is going to be like. But this sets us up for some issues. When we start to think about the older individual, and those are the ones that predominantly we'll be caring for, it doesn't mean that we aren't going to be caring for younger people. You know, catastrophes do happen to younger people, but for the most part, the people that need our services are usually those that are aging and need some additional help. So when we start thinking about things that your patient might not have the energy for, we're going to think about things like socializing or talking, toileting, bathing, eating, grooming. These are all the things that we are there to help them with. And even though we're there to help them with these things, they might still say, I'm too tired to whatever. Because we have to understand that even though we're the ones performing the action, it still is going to take energy from our patient. Now, if our patient only has this much energy to get through their day and they have to do all of these things with that energy, by the end of the day, they might be completely out of energy and they're not going to eat well tonight at dinner. If they're not eating well tonight at dinner, what do you think is going to happen to tomorrow's energy levels? They're going to be lower. And this can set up this, what we call downward spiral or failure to thrive situation where their energy levels get depleted. They can't eat to keep up that energy level. And then tomorrow is worse. And because they're so tired, they don't eat. And this leads to a very rapid decline. So this becomes very, very important for us to understand and manage. Good. All right, let's talk about this level of energy. So let's go back one slide. That's what your 82-year-old person has to work with. And I'm generalizing here, okay? But I want you to think about that little bit of energy. Now, think about where you are on this scale. And imagine losing that much energy and how it would affect you. So let's go back to, let me go back to here. Let's go back to our day-to-day activity with our older patients, okay? When you're caring for an older patient and they have to do all of these things, let's think about how much energy they're going to take. Because right now you're just focusing on the task itself. You're missing a critical part of this. The first thing that somebody has to do when they wake up is get out of bed. That means they have to stand up. Have you ever seen an older person try to stand up? It looks like this. Nope. Just give me a second. How much energy did that take? A lot. It took way more energy to do that than if I had simply stood up. Now, you're not going to think about that unless I bring it to your attention. Let's go back a slide. This is all we got to work with. And we got out of bed and it took that much energy just to get up. So now that we're up, we're going to walk to the bathroom and sit down on the toilet. And then when I'm done sitting down on the toilet, what do I have to do? Stand back up, and I'm going to do that whole rocking and rolling thing again. And I finally stand back up, and then I've got to walk to the room, and I'm going to get dressed. But man, I'm too tired, so I'm going to sit down to get dressed. And then I have to stand back up, and then I got to get to the dining room. And when I get to the dining room, I'm going to sit down in the chair. And after eating, I'm going to have to stand back up. Are you starting to see that this level of energy isn't going to last very long? It's not just about these actions, guys. It's how they get to and from those actions. You can bathe somebody all day long, but they still have to get undressed and get dressed. And even if you're doing the work, it's still action on their part. So when your patient says, oh, I don't have the energy for that, you need to believe them. They can't just magically make that energy appear. But what if we could use some of our energy, loan them some energy? That might allow them to get all of these things done and still have enough energy to eat tonight so that tomorrow's energy levels are okay. And that's what we're going to do. We loan patients some of our energy, and we do it in the form of strength. Strength and energy has an inverse relationship. If you're weaker, it takes more energy to do something. If you're stronger, it takes less energy to do something. Now, remember, you're on the stronger end of the spectrum, and you have excess energy, right? So you're on the opposite end of the spectrum as your patient. They are weaker and have less energy. So when we help our patients stand up, particularly by using a gait belt, we relieve that energy expenditure from them. We loan them some of our strength and our energy and help them stand up so that they have enough energy to get through the rest of the day and take care of the things that they need to take care of. That's why a gait belt is used. A gait belt loans the patient some of your strength and energy. Good? Make sense? Okay. So when you understand why a gait belt needs to be used, it's for the patient's well-being, not yours. Gait belts don't really have anything to do with safety. A lot of people think if I put this around the patient's waist, they won't fall. This is nothing more than a belt. If you wear a belt, does that magically keep you from falling? Might keep your pants from falling, but it doesn't do anything to help you. This does not keep our patients safe. What it does is allow for the transfer of energy. Okay, so we got to understand what it is. All right, so let's look at page 66. And here, you can see all of the principles that are involved in this skill. They're all spelled out for us here. We're going to follow our care plan. We're going to do our opening, evaluate if we need gloves. We'll talk about this in a minute, and we're going to do our closing. This is skill specific, and down here is your test information. Somebody with your level of experience should be able to do this skill, ambulate a resident with a gait belt, within 5 minutes or less. It's a real person, another testing student, and they'll be sitting in a chair at the beginning of the skill. But in order to understand how to do this skill, we have our last principle to learn, and that's shoe rules. So if you look on page 67, at the top of the page, we have our care plan. It says ambulate the resident at least 10 steps. That's 5 steps in one direction, turn around, 5 steps back. It's a round trip. Use a gait or transfer belt. Patient will be sitting in chair at side of bed with shoes on. Easy. And patient is able to walk but needs assistance to stand. This is an easy skill. You're going to help somebody stand up, let them walk 5 steps, turn them around, let them walk 5 steps back, and help them sit. That's it. That's the whole skill. This is just as easy as range of motion. Takes about the same amount of time. It's not a hard skill. But we have to understand why we're doing this. So here's our shoe rules. This is what we're going to follow when we're doing this skill. Just like any other principle, these are not going to be on our care plan. Our care plan will say nothing about the fact that they need shoes on to walk. Care plan does say that they already have shoes on. That's fine, but it doesn't tell us they need shoes to walk. It doesn't tell us that slipper socks are not enough. Now, we talked about that in a previous lesson. Slipper socks do not protect against slips effectively. They definitely don't protect against pathogen transfer. So if you're going to walk the patient, they really should have shoes on. Thankfully, for the test, they're going to make this super simple. Everybody's already wearing shoes. You're good to go. When we're putting a gait belt on, we need 4 fingers. I'm going to go through each one of these and show you as we go through. Patient's feet have to be flat on the floor, and we're going to count to 3 before we lift them. After we lift them, we're going to ask if they're weak, dizzy, make sure they're okay to go. And then when we go to sit them back down, we want them to back up so they feel that chair behind them before they sit. And we're going to use proper body mechanics, which is not the way you think it's supposed to work. All right. So the first thing we have to know is that slipper socks are not enough. They do not keep the patient safe. They may help minimize fall risk, but they do not prevent falls. Nothing does except shoes. So put shoes on the patient. If your patient doesn't have shoes for whatever reason, you walk into the patient's room and Ralph does not have shoes, let the nurse know. Hey, I'll walk the patient, but they don't have shoes on. I personally would put a second pair of slipper socks on that I take off before the patient gets back into bed. So we're not providing a pathogen transfer in situation. When you put the gait belt on, it has to be snug. This is the #1 error that is made with gait belts. So this is a gait belt. It's a flat canvas belt. It has a metal buckle on one end and just a free end on the other. It does not matter whether the belt faces this way or this way. Nobody cares. What does matter is that the tag is inside, like every other article of clothing. You're going to put this around your patient's waist, not yours. I'm just going to demonstrate on me. This goes around the patient's waist. And once you get it around the waist, don't let it be twisted. It's got to be flat. When you get it around their waist, the free end goes through the first guard by the alligator teeth. So Jake, you want to zoom in for me? So this goes around the patient's waist, tag side in, this free end. Let me know when I'm at, because I can't see.
Is that good? I think that's good.
Oops. I got to move so they can see. Sorry. Bring it over this way a little bit, Jake.
Set up autofocus here.
There. That way they can see. Okay. So we've got this buckle. You've got a guard, teeth, and guard. So you want to open this up and put this end through the first guard by the alligator teeth, and you're going to pull it the direction the teeth are pointing. See how all those teeth are pointing that way? You want to pull it in that direction. If you pull it this way, it's not going to help. You want to pull it in that direction just until it's snug. And you want it snug against the patient's waist. If it's too loose, if you've got this belt too loose, when you go to lift the patient, it's going to go up underneath their breasts, under their arms, or they'll just slide right out of it. So you really want to make sure that you pull this so that it's snug, and we're going to check it with 4 fingers. I'm going to take 4 fingers and place the 4 fingers under the belt, between the belt and the patient. I should only be able to fit 4 fingers. Then, once I've got it snug enough, I'm going to take this free end and put it through the second guard to lock it in place. Now that it's locked in place, it's not going to go anywhere. I can pull on this and it's not going to go anywhere. This free end, if it's hanging down in your way, you can just put it right inside the belt. Now, to remove a gate belt, you take it out from the second guard, but instead of pulling the tail like we did to put it on, this time we're going to pull the buckle. So to put it on, we pull the tail. To take it off, we pull the buckle. On tail, off buckle. And then you just remove it. Don't slide this on the patient. Listen closely to this sound. Do you guys hear that? That will cause a burn against the skin. So when you take this off, we don't pull it. We put our hands behind and grab it, or you can loop it up and over, making sure you're holding that buckle so it doesn't bonk them in the head. Okay, good. Questions? Thank you, Jake. All right. Okay, so we've got our patient sitting in a chair. We put the gate belt on. We made sure that it was snug and it's locked in place. We checked it with 4 fingers. And we're getting ready to stand our patient. Now, their feet have to be flat on the floor. It's not, most of you guys are tall, relatively tall. You probably don't really think about this because your feet have always hit the floor. But shorter people like me, my feet have never landed flat on the floor ever in my life. I've got short legs. And you probably don't notice it because when I sit, I always sit just a little bit forward so my feet are flat on the floor. Or if my hips are all the way back, I'm up just on my tiptoes a little bit. And it's not obvious to you. And if you're not short, this may not ever have occurred to you. But if you try to lift me from this position and I'm on my toes, I'm going to tumble forward because I don't have a stable base of support. So for me, when you put this gate belt around me, you're going to have to ask me, can you scoot forward for your feet to be flat on the floor? You want to make sure the feet are flat on the floor. So for me, I have to scoot forward a little bit so my feet are flat on the floor. When you lift me, now I've got a stable base of support. So for the test, you don't know what size your patient's going to be. When you're out there working with patients, you don't know how tall they are. So you want to make sure that you say, are your feet flat on the floor before you start? Good. Before we lift a patient, we always make them a partner. So I'm going to count to 3. 1, 2, 3. We're going to stand up. And when they stand up, I'm going to hold that gate belt. Now, where I hold the gate belt actually matters. You don't want to hold the gate belt in the front and pull here because that's going to make your patient come this way. It's not going to have them move as a unit. You want to hold the sides or the back of the gate belt. Remember, most of our weight is back here. So around the back or the sides, if they're larger, you want to hold here. And when you hold, you want to hold like this. So you're going to grab the sides or the back, bless you, and you want their hands on your shoulders as you lift them to a standing position. So if you go forward a page, if you go to page 64. Bless you. No, it's not there. Okay, I'm not sure where it's at. I'll show you in a minute. You're going to count to 3. Where is that picture? I got to learn this page. Oh, 61, sorry. 61. Up in the second column at the top, page 61, you see a picture there. Do you see how she's kind of leaning back because her arms are down? The patient. Do you see that patient? That is not upright. So when you are lifting a patient, you want their hands on your shoulders like this, not around your neck, not holding on. You just want their hands resting on your shoulders so that as you lift them, you're moving them as a unit. And there's less likelihood of them being off balance because remember, balance is affected by age. We learned that in chapter 4. Once you get them standing, you want to ask, are you dizzy? Is everything okay? Anything I need to know? I want to know here. I stand a patient up. I want to know how they're doing. I don't want to wait till we get somewhere over here. Because if they start to get wobbly, if they don't look right, if they get pale, sweaty, put a hand out, put a hand up, put one to their stomach, slow down. I mean, they'll give you a million clues that something is wrong in their life. If I wait until those clues show up, I don't have an exit strategy. What am I supposed to do? Now, what most of you will do is try to rush them back to that chair. If they're not tolerating a slow walk, what makes you think they're going to tolerate a rush? They're not going to make it back to the chair. Not ever. So I don't want to wait till I'm over there to find out we got a problem. I need to know at the chair that we have a problem. Now, if I ask them, are you dizzy? And they say, no, I'm good. And we start walking and there's a problem, don't rush them back to the chair. That's not going to work. Get them sitting on the ground right where they are. Down we go. You can back them up to the wall, help them slide down. You can use your body, pull them towards you with that gait belt, slide them right down to the floor. But you need them on the floor. Because a patient sitting on the floor can't fall on the floor. Falls are when things happen. So we need them on the floor. We're going to send somebody to go get the nurse. Don't leave your patient alone. Yell for the nurse. Send another staff member to go get the nurse, get somebody to help, and let that nurse evaluate the patient and figure out the next step. We can wash off whatever they came into contact with on the floor. I guarantee you, I've got soap and water for that. I can't wash off a broken hip. Good? Make sense? You may have a written test question that says you're walking a patient, you're 7 steps from the nearest chair, and your patient complains of dizziness and nausea. What do you do? Rushing them back to the chair, never the right answer. Getting them sitting on the floor, right answer. Good? I know it's a lot of people struggle with that because they just want to get the patient back to safety. They're not going to tolerate it. Once you get them back to the chair, so we've gone 5 steps, turned around, came back, we're backed up next to the chair. That patient needs to know that chair is behind them before they sit. Right now, I can't feel that chair behind me. I'm too far away. You're asking me to trust you? I don't know you. Why would I trust you? And chances are I have been dropped by a caregiver at some point. Almost every patient has. They're not going to trust you. So what you want to do is ask them, can you back up until that you feel that chair behind your knees? So back up until your knees hit the chair. Let me know. I feel the chair. Okay, now we're going to sit. I'm not asking that patient to trust me. I'm asking them to trust the chair. The big difference between the two. Good? All right, we're going to use proper body mechanics. We do not stand in front of the patient while we lift them. And a lot of you have been taught to do this. You stand in front of the patient, knee to knee, toe to toe, and you lift the patient towards you. Don't do that. There's a physics principle here. Every action has an equal and opposite reaction. You guys remember learning that in 8th grade? What that means is if I'm going to lift a 150-pound patient toward me, right? I got the gait belt, their hands are up here. I'm going to lift 1, 2, 3. As that 150 pounds is coming up toward me, my body is going to go back with 150 pounds of force, bless you, on my lower back. That's a great way to blow out your discs. Don't do that. That's bad body mechanics, but even more dangerous is the fact that as this weight is coming up towards you, if you can't stabilize your weight and theirs, you're going to go over backwards and your patient's going to land on top of you. So standing in front of somebody, not a good strategy, not good body mechanics. You can cut, well, that picture doesn't show it really well, but if you go onto YouTube and just type in ambulate with a gait belt and watch some of the videos, you'll see most of them have the patient right in front of them. They pull the patient up toward them, and every single one of them wobbles and takes a step back. That's not stable. Okay, good. So instead, we're going to use something called an oblique angle. What that means, these are the older slides. I got to get the slides updated. So if you look on page 61, there in the first column, you see the lady sitting in the chair, and you see two footprints. One is in front of her feet going across. The other is beside her feet. Do you see that first graphic there on page 61 in the first column? So what this is, you see that here on the screen too. What this is, if I've got a patient sitting in this chair here, so I'll be the patient for a second. I'm sitting in the chair. You could draw a box around me. You could draw a line in front and one on each side. And I'm going to use that box. So as the CNA, my patient's sitting in a chair, I'm going to take this foot and put it in front of those feet. That way they can't slide out. I'm going to take this foot and put it parallel to the chair. And then they're going to put their hands on my shoulders. I'm going to bend at the knees, not at the waist. I need my legs to do all the lifting. I'm going to bend at the knees, go around behind the back, their hands on my shoulders, and 1, 2, 3. Just like that. That keeps me stable, but it keeps my body upright and not subject to the offsetting forces of their body weight. Okay. Good. So this skill is actually pretty easy. We're going to read the care plan. It tells us to walk them 10 feet, tells us they're sitting in a chair, already have shoes on, and they can walk. They just need some help to stand. So knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to take you for a walk. How does that sound? I'm going to close the curtain, wash my hands, get my gait belt. I'll be right back. Come back with a gait belt, put it around their waist. Make sure it's snug. Lock it in place. Check it with 4 fingers. Place your hands on my shoulders. I'm going to stand with 1 foot in front, 1 foot beside. Grab the gait belt, and on the count of 3, we're going to stand. 1, 2, 3. We're standing. How are you feeling? You good? All right, I'm going to let you lead. I'm going to come around beside, slightly behind, into one side, and I'm going to hold the gait belt in an underhand grip as they're walking. Because this lets me feel if they start to wobble or they slow down or whatever symptom they're having that tells me something is wrong. And they're going to walk, and I'm going to follow. And my focus is on them, not on anything else, them. And we're going to walk 5 steps wherever the evaluator, and the evaluator usually gives you like walk to the door and back, walk to the desk and back. They'll give you a destination. And once we get to the halfway point, we turn around and we go back to the chair. And then I turn them around, ask them when they can feel the chair. And I'm going to use that same body mechanics, 1 foot in front, 1 foot beside. And on the count of 3, we're going to sit. 1, 2, 3, lower the patient down, take the gait belt off. Do my closing. Thank you very much. Is there anything else I can get for you? Are you comfortable? Here's your call light. Would you like a magazine? Open the curtain, wash my hands. My skill is done. This is a skill I would want. There's no curveballs here. With the exception of some of the evaluators may put a overbed table in your pathway. Remember I said they're going to give you a destination like walk to the door or walk to the table. Some evaluators might actually put this table in your pathway on purpose. Check your walkway before you lift your patient, because once you've got that patient standing, you can't leave them to go move an obstacle. So always look at your environment, your walkway, and make sure there's nothing in your way before you start walking the patient. That is a curveball a few of the evaluators have started throwing in. It's good to know.
With that being said, should we be closing the curtain? Because we got him up walking, now all of a sudden he's gonna run on the curtain, we're gonna have to open it, which means we gotta let go of him.
Yeah. So for the test, the curtain doesn't go all the way around the bed. It's not an issue. This skill doesn't require closing the privacy curtain, so you can do this skill without closing the curtain at all because we're walking the patient. But for me, personally, I'm going to take this on a case-by-case basis, and this is why. If my patient is sitting in this chair and all they have on is a hospital gown, it's open in the back. This guy's going to have full moon over Spring Hill, right? So when I stand him up, I probably want some privacy while I get a second gown on him. So for me, I'm going to take it on a case-by-case basis. If I need to get him dressed for company, privacy curtain. If he's already good to go and we can walk, no privacy curtain. For the test, it's not a graded checkpoint either way. Okay.
If we forget about the obstacle and we're like partway through, should we just like, once we get to it, should we just move it and be like, correction, I would have done this before?
Yeah, I would definitely correct it. Yeah, I would say I would make sure that there's no obstacles in the way before. And yeah, you can easily, because it's on wheels, you can easily move it as you're walking. But here's the problem. This is what they're going to grade you on or think about. If you're paying attention to that obstacle, who are you not paying attention to? The patient. And that's what the skill is all about. So I would at least say, I moved the obstacle, but say I would have cleared the pathway before I started walking. That way they know that you understand that's important. If you just move the obstacle and don't say anything, they're going to assume that you don't understand where your focus needs to be. Are you starting to see that the test it's always about the patient? Every checkpoint is about the patient, not about us. All right. Okay, so here are our steps. We're going to remove the obstacles first. Put the gait belt on over the patient's clothing. Make sure it's snug enough. Check it with 4 fingers. You're going to hold the gait belt around the back. Use that oblique angle, 1 foot in front, 1 foot beside. Have them put their hands on your shoulders, and you're going to lift. There's the picture I was looking for. So those of you playing along at home, if you don't have their hands on your shoulders, they end up in a kind of a backward posture, which can throw their balance off. So hands on your shoulders. As they're walking, you're going to stand slightly behind and one side, holding that gait belt with an underhand grip, letting them lead, but paying attention to them. We'll ask if they're dizzy when we stand, and as we walk, just check in with them, make sure everything's going okay. And then when we get back to the chair, we want them to back up till they feel it and then help them sit using that same method. Remove the gait belt without pulling it against their skin and make sure they're seated properly with their hips all the way back or feet flat on the floor. So these are the checkpoints that relate to this skill specifically. Good? All right, I'll show you this video. It's a very quick video, and then we're going to get into partial bed bath. Go ahead, Jake. Good afternoon, Mr. Jones. My name is Patty, and I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. Do you feel like going for a little walk?
Yes, that'd be lovely.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. I'm going to clear the walkway of obstructions. We'll close the privacy curtain and wash my hands. Now that I have clean hands, I'll get the gait belt. Mr. Jones, I see you have non-skid footwear on. Does it fit appropriately?
Yes.
Very good. This gait belt I'm going to put around your waist. It's going to help me lift you to a standing position and provide a little stability as we walk. Is that okay?
Yes.
Okay, I'm just going to slide this around your back. Okay, and lift your arms and relax. We're going to put the free end through the first guard by the alligator teeth and pull it so that it tightens the belt. We want the belt to be snug. We want to only be able to fit 4 fingers between the belt and the patient, and then we'll lock it in place by putting the free end through the second guard. And then we'll place the free end through the top just to hold it in place. Okay, Mr. Jones, your feet are together. In just a few moments, I'm going to have you place your hands on my shoulders, and I'm going to place my hands around your back. And on the count of 3, we're going to stand together. Okay?
Okay.
So I'll put 1 foot in front of your feet to keep them from sliding out, 1 foot beside the chair to keep me at an oblique angle. Go ahead and put your hands up here. And on the count of 3, we're going to stand. 1, 2, 3. Thank you very much. Are you dizzy at all?
No.
Okay. So at your pace, when you're ready, I'm going to have you lead and we're going to walk to the wall. I'll walk slightly behind and to one side, watching the patient. Okay, and go ahead and turn. And then we're going to walk back to the chair. Are you dizzy at all?
No.
Very good. So when you get to the chair, if you can turn around for me and back up so that your knees hit the chair, come my way just a little bit. And on the count of 3, can you feel the chair behind you?
Yes.
You're going to place your hands on my shoulders. Go ahead. I'm going to put 1 foot in front and 1 foot beside. And on the count of 3, we're going to lower. Ready?
Yes.
1, 2, 3. Being careful to bend at the knees and not the back. I'll remove the gait belt by taking it out of the second guard and then removing it from the first guard. We're going to remove it by looping it over the patient, being careful not to let any part hit the patient. And are you comfortable?
Yes.
Could you slide back so that your hips are against the back of the chair? Very good. I'm just going to go put the gait belt away. Are you comfortable, Mr. Jones?
Yes, ma'am.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your environment is clean. I'm going to hand you your call light. Here's your call light. If you need anything at all, just press that red button and somebody will be happy to help you. I'm going to open your curtain and wash my hands. After washing my hands, I'll review the care plan, make any corrections that need to be made, and then tell the evaluator my skill is done. All right, any questions on that one?
For the gait belt, does every patient get their own, or does it need to be disinfected?
No, it's similar to a chair, right? Everybody sits in a chair. It's not really big because it goes on over the clothing. It's not having direct contact with the patient's skin. Now, there are situations if your patient has some sort of communicable disease that is spread by contact, then they would get their own gait belt. But for the most part, in a lot of settings, CNAs are issued a gait belt, and then you just use that on all the patients. Okay? If you get the practice kit, there is a gait belt in there, and that you can use in your clinical setting, as that's your gait belt. I would take a Sharpie marker and write your name on it just so that it doesn't walk. All right. Questions? Last skill for today. So after today, starting next class, you should have some practice time in class. You might maybe get 5 or 10 minutes today, probably not much. But starting on Wednesday, you'll have probably about a half hour, 45 minutes. Monday, you'll have about an hour to an hour and a half. Wednesday, you'll have about 2 hours. So from this point on, you get practice time in class. And we have all of the supplies here for you to be able to use to practice. I suggest you take advantage of the practice time that you have in here. If for whatever reason you don't want to practice in here, if you're shy or don't want to do it in front of others, then make sure that you're practicing somewhere. Okay. All right. So if you go to page 126, we're going to learn about partial bed bath. If you look at this, every single principle that we are learning is going to be involved in this skill except for shoe rules, because your patient's laying in bed. They're not getting up. So shoe rules doesn't apply, but everything else does. So this skill puts everything that we've learned so far together. It's also the longest skill that we have. Somebody with your level of experience, which is none, should be able to do this skill in 19 minutes or less. That's a long, long skill. But the good news is that you already know almost everything you need to know to do this skill. Almost. There's one thing I have to teach you. But the rest of it is just putting together principles that we've learned so far. So it's not a hard skill. It's just a super long skill. This is going to be done on a mannequin, not on a live person. So again, you're generally speaking, you would do the skills that you would be doing on another person. And then this is the last skill in your set. All right. So we know to follow the care plan. We know how to do the opening. We know to evaluate if we need gloves. And since we're working around the face, there's body fluids. We need gloves. We're also cleaning the chest. That's personal skin gloves. We know to use a barrier on our table. A privacy blanket's going to keep the patient covered while we clean them. Linen rules apply. Your patient should always be in the middle of the bed. You know all the washing rules. You know how to clean the basin, and you know how to do the closing. This has a lot of steps, but 99% of them, you already know them all. We just have to put them together. Now, there is one thing that you don't know, and that's what we're going to work on now. Page 127 has our step-by-step instructions. Care plan is at the top of the page. Supplies are at the bottom. Look at that list of supplies. Woo! There's no way around that. You have to memorize your supplies. So if you do not have flashcards, you should be making flashcards for supplies, because nobody's going to tell you, hey, go do a partial bed bath and you're going to need a basin, soap, lotion, patient gown, 4 washcloths, 2 towels, and a privacy blanket. Nobody's going to tell you that. You have to know it. If you read the care plan at the top of page 127, it says to give the resident a partial bed bath and back rub. Wash the resident's face, neck, chest, abdomen, back, and 1 arm and hand. What if the patient has 2? They don't care. You're going to do 1. You get to choose which one. They don't care. Where do those evaluators want to be? At home in their pool, drinking their margaritas, and you are keeping them from that goal. If they have to watch you wash 1 arm, rinse 1 arm, and dry 1 arm, and then go to the other side of the bed and do it all again, they're going to go stark raving mad. So the care plan just tells you to do 1. They don't care which one. But the best way to remember this is this, right? Because that's a whole lot of words, isn't it? Face to waist, front and back. Face first, no soap. So face to waist, front and back, face first, no soap. Just remember, one arm. All right. So we have learned everything on washing rules except for one little thing that we haven't talked about yet on washing rules. And that one little thing is what we're going to focus on now. It is use leaves method for wet body openings. What does that even mean? Use leaves method for wet body openings. Before I explain what that means, let's review washing rules real quick. We don't put soap in the basin because we need water for rinsing. We're going to use a paper towel to turn our faucet on. It should feel warm, not hot, not cold. And we're going to check it. Who else checks it? The patient checks it. We're going to change that water if it becomes cold or soapy. Whatever we wash, we rinse. Whatever we rinse, we dry. We don't get our surface wet, so wring out your washcloths really well. No drippy wet washcloths here. We want to keep your surfaces dry. And anytime we put lotion on, we warm it up first, and then we wipe off the excess. You guys remember all that? All right, let's learn about this then. I passed out washcloths for you. This is just a plain square washcloth. Everybody has one of these in front of you. Generally, they're folded in half and then in half again, which makes a square. Everybody have your little square? Instead of looking at it like a square, though, we're going to look at it like a diamond. So instead of a square, we're going to look at it as a diamond. Now, when you're holding this in that diamond shape, you have a couple of different corners to it. You have a corner that has folds, okay, where the fabric folds over. You have another corner where the fabric folds over. You've got this one where it's a point. It's just the center point of your washcloth. But up here, you've got this section which have your free leaves. These are leaves. So if you hold your washcloth in that diamond shape and you take your hand and put the diamond on your hand with the free corners at the top, you want to tuck in one side and the other side. So this is what your washcloth should look like. So we have a diamond with our free corners at the top in our hand. One corner gets tucked between your pinky and ring finger. The other corner gets tucked between your thumb and index finger. And now we've got a washing surface. If we wash something, we can fold that leaf down, which traps the contamination underneath, giving us a new clean area to work with. So we can wipe something and fold that down, giving us a new cleaning surface to work with. We can wipe something and fold that down, which gives us a new cleaning surface to work with. And we can fold that down, giving us a final cleaning surface to work with. Now, this is useful if we're going to be washing a wet body opening, like eyes, nose, mouth, genitals, rectal area, wounds, rashes, sores, or incisions. Anybody remember hearing these words when we talked about infection control? Remember we talked about portals of exit and portals of entry. All of these are portals of exit, which let things out, and portals of entry, which let things in. So when we're washing these areas, we don't want to use the same area of the washcloth on more than one area. So we use it and then we have to fold it. So now our next stroke, we have a clean working surface. So we're not letting anything in, or anything that did get out stays out. Make sense? This is called the leaves method. And since for this skill, our care plan told us to wash the face, we have eyes, nose, and mouth on the face. So we're working around wet body openings. Now you're going to see this again with peri-care on Wednesday and with catheter care on Monday. We're going to use this method again for 2 more skills. So again, this is just a picture demonstration. We have our diamond shape with our free corners at the top in our hand with our 2 sides tucked in. So I have control over it. That's what we see here. We can wipe something and fold that over. And my thumb is just kind of holding that flap down. That's what you see here. We can wipe something and fold that over. We can wipe something and fold that over. We can wipe something and fold that over. Now, since I'm using this on the face, what I'm going to do is take the first leaf and wipe the eye, inner to outer corner, and fold that over. I'm going to take this second leaf and wipe the other eye, inner to outer corner, and fold that over. I'm going to take the third leaf and wash the skin of the face and around the mouth and fold that over. And then I'm going to take the fourth leaf and wash the nose. I always do the nose last because boogers, right? So, and then I can fold that over. Good? Make sense? All right. So here's our care plan. Give the resident a partial bed bath and back rub. So time out real quick. If your patient needs a bed bath, they might need a full bed bath. They may need everything washed, which means that we're washing the body, we're washing the peri area, we're washing the backside, we're washing the legs and the feet, right? So we're going to put all of these skills together and do a full bed bath. But for the test, they don't want to watch you do all of that. That would take forever. So they break this up into little tiny pieces like foot care, hand and nail care, partial bed bath, peri-care, right? They break it up into little pieces. So if it's a partial bed bath, partial, that care plan has to tell you what parts they want you to wash. Wash the resident's face, neck, chest, abdomen, back, and 1 arm and hand with soap and water. That's what we're going to use. Now for the test, they give you a spray soap. It's not like the hand soap that we have in the bathroom where you squish it, it's all liquidy, it suds up really well. Spray soap doesn't do that. Spray soap actually has very little suds to it, and it's easy to rinse off, and it's very mild on the skin, so it's not as likely to cause that drying effect. We use the spray soap in clinical settings where we know we're not going to have good running, rinsing water. Good? Make sense? All right. Provide a brief back rub with lotion. We are not massage therapists. We're not deep tissuing anything. That is not what we're doing. That's not why we're there. This is to promote circulation, to wake up those nerve endings because patients laying on their back, squishing all of that down. But it's also to help them feel better. Remember when you were a kid and you were sick, mom, come along, rub your back just really lightly. It always made you feel a little better. That's all we're doing here. We're helping our patients feel a little better. It tells us to dress the resident in a hospital gown. Well, that makes sense because clean body deserves a clean gown or clean clothes. But we have a whole skill for you to dress somebody. We don't really need to see that for this skill. Let's just use a gown. Our care plan tells us that. Patient is lying on back in center of the bed, can roll as directed, but is too weak to assist with bathing. Now, this is a mannequin. Our care plan says she can roll as directed, so you don't have to do the whole arm up, arm over, leg bent, leg angled, all of that. You're just going to roll the man. But remember, she's a mannequin. She's not really going to help you. You're going to have to roll her. Once you get her on her side, though, there's a problem. So remember, before we turn our patient on their side, we always scoot them toward us first so that after we roll them, They're in the middle of the bed, right? Well, here's the problem. I need 2 hands for this. I've got to wash the back, rinse the back, dry the back, give them a little lotion with a back rub. A mannequin is like a Barbie. A Barbie does not lay on her side by herself. It's very difficult to get a mannequin to stay on their side. They just don't. Humans can, but mannequins not so much. So for the test, the evaluator knows this, and the evaluator will actually be on the other side of the bed. When you turn that mannequin over, they'll automatically just reach over and hold that mannequin for you. If they don't, you can ask them, hey, can you just hold the mannequin? That's fine. But usually they'll just reach out and hold it because they know it's a Barbie doll. It doesn't lay on its side. Good? All right. So we're going to wash the face first using that leaves method, but no soap on the face. Soap gets in the eyes, it stings, it dries the skin. No soap on the face, just water. So we're going to wash the face using that leaves method, inner to outer corner, fold it, inner to outer corner, fold it, face, fold it, nose last, and then we'll dry. Remember, we use wet leaves method on wet body openings. Bring your washcloths out well, guys. Please don't have drippy wet washcloths because if that sheet gets wet, your patient has to lay on a wet sheet. Is that comfortable? No. So don't let the sheets get wet. Now, we are going to put a towel under the patient while we're cleaning them to try to keep that sheet as dry as possible. But during the test, if you notice you got that sheet wet, you need to say out loud, I would change the sheet before I ended the skill. They're not going to make you change a sheet, but you better acknowledge it because otherwise that evaluator thinks that you're going to leave that patient in a wet bed. And that's icky. So no drippy wet washcloths. We're going to support the arm from below when we lift. Don't lift from above. Anything we use, after we use it, we set it on the barrier, not on the bare table. It's got to go on the barrier. And when we turn the patient over, you're just going to wash the back, rinse the back, dry the back. Nobody cares how you do it. Just wash, rinse, and dry the back. This is probably the easiest part. But then once you've done that, you need to give them a brief back rub. Now, a brief back rub is just that, brief. So I'm going to take some lotion, rub it in my hands to warm it up. I'm going to start at the bottom of the back, near the butt area, and I'm going to go up in small circles to the shoulders and come back down. We'll do that 3 times. Small circles to the shoulders, come back down, and small circles to the shoulders and come back down, and that's a back rub. We're going to make sure they're in a clean gown. The test does not care when you do this. They do not care when you do this. But remember I said that time management is important in your daily work? The way that I am going to show you to do this takes the least amount of time. So if you've got a patient and we've washed their whole front, right? Face, neck, chest, abdomen, one arm and hand, which is what our care plan told us to. I'm going to put the new gown on then. The clean gown goes on then. I'm done with the front, the clean gown goes on. Then when I turn the patient over, wash the back, rinse the back, dry the back, use some lotion, a little back rub. All I have to do is tie that gown and put it back on their back and I'm done. If you don't do it that way, if you wash the front, turn them over, take care of the back, you got to put them back on their back, take off the clean or the dirty gown, put on the clean gown, turn them back on their side so you can tie the gown, turn them back on their back and get them back to the middle of the bed. That's more steps, more time. So once the front of the patient is cleaned, take care of the gown. Turn them over, clean their back, give them their back rub, tie the gown. Done. It's a time-saving method. Good? All right, so we are going to use a barrier for this. We'll get our barrier first, get all of our supplies, put them on the barrier. We're going to get our water using a paper towel. We'll check it, make sure it's warm, let them check it. And then we're going to untie the gown and put a towel on the bed to protect the bedding from getting wet while we do this skill. We're going to make sure that the patient's covered with a privacy blanket during this skill and put on our gloves. First thing your gloves should touch is the patient. So if you put your gloves on before you did any of that other stuff, your gloves are dirty by the time you get to their face, and that's no good. We're going to wring out our washcloth really well. We'll clean the first eye, inner to outer corner. Fold the leaf, clean the second eye, inner to outer corner, fold the leaf, clean the skin of the face, fold the leaf, nose last. And then we'll set that aside and dry all of those areas. We're going to wash the front, every part that the care plan told us to. So the neck, under the chin, the chest, abdomen, up the side, one arm and hand. Whatever we wash, we rinse. Whatever we rinse, we dry. And then we're going to change that gown out. Once we have the clean gown on, we'll scoot the patient toward us, turn them over onto their side, wash, rinse, and dry the back, give them a little back rub, warming the lotion first and wiping off the excess. Then we're going to tie the gown. We're going to leave the patient in the middle of the bed while we clean everything up. Remember, we still have gloves on. Should we take that privacy blanket off with gloves on? No. So we're going to leave the patient right where they are. She's fine. She's good. We are going to take care of our soiled linens, put our gown in dirty linen. We're going to clean our basin, store our supplies, and then we can take our gloves off. Once we take our gloves off, then we can remove that privacy blanket and pull that sheet up. Remember, that sheet's going up right next to her face. We don't want to touch it with dirty gloves. Take the privacy blanket off, put it in dirty linen, and do our closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine? Your bed's in low position, environment is clean. Open the curtain. Here's your call light. If you need anything, let me know. Go wash my hands. My skill is done. You getting tired of hearing the closing yet? So that is how to do a partial bed bath.
When you were doing the neck down and the right arm and stuff,
Yep.
was the privacy blanket, were you working under it?
Right.
Or you were working under it.
Working under. So I'm going to hold it up and,
Okay.
and clean.
Okay.
Now, if I have to move the breasts to clean under them, I want to use the back of my hand to lift a breast to clean under, not the palm of my hand. Right. So using the back makes it a little less personal. So use the back to lift. Now, in that case, I'm probably going to have to move the blanket down to be able to lift the breasts to clean under so that I can visualize. Because remember, we're supposed to report anything we notice. So I do have to visualize a little bit. Now, I'm going to show you the video for this. And what you're going to see during the video is the first part of me cleaning the torso. I'm doing it while holding the blanket up and providing privacy. Then I'm going to announce to you guys, the people that are watching, that I'm going to move the blanket because for the test, they're going to ask me to move the blanket so they can see what I'm doing. So I'm showing privacy, and then they're going to say, can you please move the blanket so we can see? So you're going to move the blanket. Now, you don't have to start over. You don't have to repeat those actions you just took. They saw enough. But for the video, I do. I show you what I was doing under that blanket so you can see. Okay. Does that make sense? Okay. All right. Jake, partial bed bath. Please and thank you. Thank you. Good morning, Miss Jones. My name is Patty. I'm your CNA today. How are you? Fantastic. I'd like to provide a partial bed bath. Is that okay? Wonderful. I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. Now that I've washed my hands, I can gather my supplies. I'm going to place the supplies on the overbed table. We'll start with a barrier, unfolding the barrier so the absorbent side is facing up, and this gives us a clean place to put our clean supplies. For this skill, we're going to need 2 towels, 4 washcloths, 1, 2, 3, and 4. I need a privacy blanket and a clean gown. Being careful not to hold the clothing against your uniform. I'll bring this over to the patient area. We'll bring this over here within reach, and then I'm going to get the supplies out of the drawer that I need. We're going to open the middle drawer and remove the basin, soap, and lotion. I'll put these on the overbed table. And I'm going to get a set of gloves. Okay, Miss Jones, I'm just going to get some water in the basin. I'll be right back. I'll use a paper towel to turn the faucet on. Check the water temperature with the inside of my wrist. It should feel warm, not hot, not cold. And we'll fill the basin about a quarter of the way full. Okay, Miss Jones, I have the supplies here. Would you like to check the water temperature and make sure it's okay? It's good? Very good. Okay. So I'll put the washcloths in the water. And the first thing that we're going to do is place a privacy blanket over you. This is going to help keep you warm and provide privacy while we do this skill. We're going to spread this out without snapping it or shaking it. Placing it over the sheet. And I'm going to pull your sheet down to just below your waist. Okay, now I'm going to put the towel on the bed. This is going to help keep your sheets dry, and we'll untie your gown. So I'm going to help you sit up by putting my hand on your upper back, and on the count of 3, we're going to sit. 1, 2, 3. Very good. I'm going to untie your gown. And then we'll spread that towel out underneath the areas that we're going to wash. Come on back. Very good. And I'm going to remove the gown on the side closest to me, supporting at the elbow as I lift. Okay, Miss Jones, go ahead and bend your elbow. Thank you. And then we'll move the gown over to the other side, making sure that you're covered at all times. Now we're ready to start washing, so I'll go ahead and put my gloves on. We'll take the first washcloth, wring it out really well, and then I'm going to hold the washcloth in my hand so the free leaves are at my fingertips, and tuck in the 2 side corners. And this allows us to use a different leaf for each area that we're going to clean on the face. After wringing out the washcloth, no drippy wet washcloths, we're going to wash your face first. I'll start with your closest eye, and we're going to wash inner to outer corner using the leaves method, which is going to help prevent cross-contamination. So with the first leaf, we're going to wash the inner to outer corner of this eye. We'll fold that leaf over. And with the second leaf, we'll wash the inner to outer corner of that eye.
Fold that leaf over, and with the third leaf, we'll wash the remaining skin of the face. We'll fold that leaf over, and with the last leaf, we'll wash the nose. And we're going to put this on the barrier. Whatever we rinse, we dry. So I'm going to take the towel and fold it around my hand so I have control over it, and I'm going to pat all of those areas dry using short, soft strokes or a patting motion. We'll set the towel aside. Okay, now we're going to take washcloth number 2 and wring it out really well so that it's not drippy wet, and then we'll apply soap to the top leaf. We're going to start cleaning the neck, behind the ears, under the chin, across the neck, the upper torso, down to the breasts, keeping the patient covered at all times to protect modesty, down to the belly button, and up the side. Now, for the test, you will keep the patient covered. The evaluator will ask you to move the blanket if they would like to see. I'm going to go ahead and remove the blanket now so that you can see what I'm going to do. So we're going to move the blanket down, and I'm going to start again to show you how to clean the patient. So under the chin, behind the ears, across the neck, the upper chest, around the breasts. When you lift the breasts, we lift not with the palm, but with the back of our hand to lift the breast to clean underneath, down to the belly button, up the side, down the front of the arm, all the way to the hand, supporting the elbow at all times, either with your hand or the bed, up the back of the arm, and we'll clean the armpit last. We're going to set that on the barrier. Whatever we wash, we rinse. So I'm going to get a rinsing washcloth, and we're going to rinse all of those areas the same way. So behind the ears, under the chin, across the neck, upper torso, around the breasts, down to the belly button, up the side, down the shoulder and the front of the arm, supporting the elbow, the hand, lifting the arm from below, washing the underside of the arm and the armpit last. We'll set that washcloth back in the basin for future use. We're going to take the towel, controlling the edges, and we're going to pat all of those areas dry or use short, soft strokes. Nothing vigorous. So the abdomen, down the arm, lift the arm up, support at the elbow, dry the hand, lift the arm to dry the underside of the arm and the armpit. We'll set this aside. Now, the care plan only asked us to clean one arm. So we don't have to go over and clean the other arm. And that's because that's what the care plan instructed. In some cases, you will have to clean both arms. In that case, you would just do that at this time. But for right now, we only had to clean one arm. We did that, so we're going to dress the resident in her gown. I'm going to spread the gown out, put my hand in through backwards on the armhole, lift her hand by holding her fingers together to place the sleeve over the arm, and then I'll lift at the elbow to bring the gown up. I'm going to make sure that gown is covering her. Put the privacy blanket back in place, and now I'll go to the other side of the bed to remove the old gown and put the new one on. Okay, now I'm going to move the blanket and remove the gown from this arm by sliding it off the arm, lifting the elbow from below with a flat palm, and then this will go in dirty linen. Now I can put the new gown on this arm by putting my hand in through the armhole backwards, grasping her hand, and sliding the gown over. We're going to lift from below at the elbow and make sure that the gown is properly in place.
To be honest, no, you'll like this
Now I'm going to go back to the other side of the bed. Okay, Miss Jones, I'm going to wash your back now. So I'm going to pull you toward me and turn you up on your side, and that way you're in the middle of the bed after the turn. Okay, go ahead and slide toward me. And then you're going to roll on your side. 1, 2, 3. Thank you very much. The evaluator will hold the mannequin in place during your cleaning, during the test. Live patients, of course, can lay on their side. So I'm going to ask the evaluator to please hold the mannequin in place for me. Thank you. We'll slide this towel down so it's covering the bed underneath the back. We're going to take our third washcloth, wring it out really well, and we'll apply soap to the top leaf. I'm going to wash the back from the neck down to the shoulders, all the way down to the waist. We'll set this washcloth aside, and we'll get our rinsing washcloth. So we'll wring that out, and we'll rinse the same way we washed. The back of the neck, the shoulders, all the way down to the waist. We'll set that aside, and we'll take our towel to dry those areas. So I'm going to pat dry or use short, soft strokes and dry all of those areas. Now the care plan asks me to provide a brief back rub. So I'm going to take my lotion, put a little bit in my hands, and then I'm going to warm it up by rubbing my hands together. We're going to start at the base of the back and go up in small circles to the shoulders, and we'll do this 3 times. To the shoulders, come down, up to the shoulders and come down. And then we'll take the towel and wipe off the excess lotion. We'll remove that towel from the bed, putting it on the overbed table, and then we'll tie the gown. Come on back, Miss Jones, onto your back, and then scoot to the middle. Thank you. Okay, you're covered and safely in the middle of the bed. Let me go dispose of all of my supplies, and I'll be right back. So I'm going to put all of the supplies in dirty linen, being careful not to hold them against my uniform. And now I'm going to clean my basin, and we'll dispose of the water in the sink. Rinse the basin, and then dispose of the rinsed water into the sink as well. I'm going to set that down, disinfect it per facility policy, and then pick it up with a paper towel. I'm going to get a clean paper towel to dry the inside. I'm going to get a clean paper towel to dry the outside. And then one more for the drawer. Okay, on the way, I'll place the lotion and the soap into the basin using a paper towel. And then I will use the paper towel to open the middle drawer and slide the basin with the soap and lotion into the drawer. We'll close the drawer with a paper towel and then throw them away. I'm going to remove the barrier, throw it away, and then I can remove my gloves. Okay, Ms. Jones, I'm going to move your privacy blanket now. So as I pull the blanket up, I'll restore the sheet. This preserves modesty and keeps the patient warm. We'll roll the privacy blanket up in a ball so that trailing edges don't contaminate other surfaces. Okay, I'm going to place this in dirty linen. We'll return the table to storage, adjust the sheet for neatness and appearance. Okay, Miss Jones, are you comfortable? Is there anything else I can get for you while I'm here? Okay, let me place the call light in your hand. So there you go. The call light is in your hand. If you need anything at all, please press that red button. We'll be happy to come help you. Bed is in the low position. The environment is clean. I'm going to open your curtain and go wash my hands. After washing my hands, I'll review the care plan to make sure that everything in the care plan was addressed with this skill. I'll think about my skill and make any corrections that need to be made. And once I'm happy, I'll tell the evaluator my skill is done.
All right, we have one comment and then I'll give you your homework. So does arm washing come before the hands? Because I'm seeing the process that the eye, face, arm, and hands. So Betty, generally speaking, you go top down. So yeah, you would do the arm, the hand, but armpit obviously would be last, right? Because that's where most of the sweat and body oils and odors and things would be. So yes, you would wash the arm, the hand, and then the armpit last. All right, so you guys have one chapter of homework tonight, chapter 7. It's another skills chapter. So read the paragraphs in between. If there's a discrepancy between the skills chapter and what I'm teaching you in class, always go by me because I'm based on testing standards. All right, have a fantastic day, and I will see you guys on Wednesday. 3 classes left. Those of you who are joining us online, remember that you have access to these class wrap-up worksheets as well. If you go to flcnatraining.com, you can see the worksheets that the classes are using as well. All right, you can, just leave them there. All right, until next time, happy caregiving. Bye.